Good morning, everybody. One of the apologies for today is David, who of course is immobilised at home. He had his operation, which I think was very successful on Saturday. We've also got apologies from Camilla and Jennifer, who I think are just taking an Easter break, and Paul, who's taking a break because it's his 40th birthday, so which I sort of vaguely remember mine, but it is now quite a time ago. I'd also like to welcome the members of the public, both David, who's actually physically present, and the public who watch this on YouTube. I actually checked yesterday, and our last board meeting, there were 462 viewers, which I think actually is pretty impressive. I don't know, of course, it doesn't tell you how long they watch for, but it does mean that having these meetings on the web is, is important, because there are this significant number of people who at least watch it at some point. So if we can start with the minutes, and unless there's any questions, we can just take those as read. The action log, there are actually 3 items that were due to be covered at this meeting. One was the full pulse report, which David touched on at the last board meeting. That's still not quite ready, but it's going to come to the board at the next meeting. The 2 other items on the action log, one is getting Health Watch's perspective on the acute hospital inspection process, which Anna is going to cover actually under item 11. And the other important item, as you can remember, we had quite another one of our discussions on the which thematic reviews we should be undertaking. But David has now chosen 2 long reviews and 4 shorter ones, and we're going to cover those under item 8. So all the items on the action log have actually been actioned, which is very good. So David, if we could start with the Chief Executive's report, please.
Thank you, Michael. Good morning, everybody. Last April we launched our 3-year strategy. So the first 2 numbered paragraphs in this report are really just giving you a reprise of, I think, some of the work that has gone on to deliver the first year of that strategy over the past 12 months, and pulls out some of the progress that has been made right across the organisation. I want to emphasise, Michael, that this is something that has been taken forward through our inspectors, our inspection managers, but the people working designing new methodologies, colleagues in intelligence and monitoring, and colleagues in the National Customer Service Centre that have supported this, and then finance, HR staff that have also weighed in behind this, and of course Hillary's team in change management have contributed to this. So this really is an organisational effort. But we've landed our new inspection methodology the 1st of April, so Mike moved beyond his first and second waves, and Steve and Andrea launch the waves. We published Intelligent Monitoring, our second edition of that in March of this year, so good progress on delivering those new methodologies. The new structure became operable from the 1st of April, with the 3 chief inspectors taking on responsibility for operational staff and their managers, and the academy's begun to deliver its product. I think over 100 of Andrea's staff, for instance, have been prepared to deliver the wave inspections in adult social care. So that's moved beyond being a concept, and there's now a product that's available. We're virtually complete in terms of appointments to Deputy Chief Inspectors. Steve and myself have, along with Andrea, have another interview to do later in May. But we've made good progress in relation to that, and appointments to inspector and inspector managers and intelligence staff are taking place now, and are progressing well. Our approach has been to learn through doing, and that continues in the way that we're developing our methodologies and approaches. So good progress is being made. And on the 9th of April, we published 7 handbooks, which set out the changes to the methodology, overview reports from our 3 Chief Inspector colleagues, and a document on our approach to equalities and human rights. They're out for consultation. That consultation lasts until June of this year, and our plan then is to revise those handbooks, and they'll be available in September, and that will align with the regulations which we cover in paragraph 4 coming into force from the 1st of October. So there'll be a convergence of our handbooks setting out how we intend to inspect and the regulations. Sandwiched in between paragraphs 2 and 4 is paragraph 3, which is just flagging that the Care Bill will go back into the Commons on the 7th of May and will go between the Commons and the Lords in what's affectionately referred to as ping pong, and we expect royal assent to be given to the bill around the middle of May. In relation to the regulations, the 2 issues I just want to pull out, Michael, in terms of the update is the consultation now on the duty of candour is current and is out, and the consultation on fit and proper persons test is also out. That will be concluded in April, and then we'll be able to proceed with some clarity working with the Department of Health about how they intend to respond to the views that they've had in relation to those 2 responsibilities. And as I say, we'll be able to bring those together in September in our revised handbooks, and then begin to operate them from the 1st of October. So I think that's good progress, and I'd want to acknowledge the work that colleagues here, but also colleagues right across the organisation have done. I think the relationships with the Department of Health have been very, very productive and positive, and have helped immensely on those issues around regulation. Other issues that we've been dealing with, the NMC has been consulted on revalidation of nurses and midwives. We employ over 300 nurses and midwives, many of who keep their registration live. So how we revalidate nurses who act as inspectors or inspection managers is a key issue. So we've been involved in discussion with NMC about recognising nurses who regulate as being a legitimate part of their revalidation. So not just their clinical hands-on practice, but their working registration. And there have been a number of events to support that discussion. The Academy will pick up on ensuring that what is required for nurses that we employ to be revalidated in terms of their continuing professional development is something that we can support nursing staff in. Steve, I don't know whether you're going to mention it later, but has been leading on this work, and one of Steve's colleagues is going to be the lead for medical revalidation. The numbers are much less for us of doctors that we directly employ, but we do employ a number, and we'll need to attend to their revalidation also. 2 items on the Mental Capacity Act. First is the House of Lords have published a report following their deliberations on the issues of mental capacity. They made a number of recommendations, a number which apply directly to us in terms of how we should take forward an assessment of how organisations are using the mental capacity legislation as part of the way that they deliver services. And that's a recommendation that we're happy to accept, and indeed are building into the way that we inspect. They also made some fundamental challenges, however, to the Act, and it's for government now to respond to that report from the House of Lords. Some of those changes are likely to need either primary legislative change or secondary legislative change, in which case that's at least 2 years away, I would have said. And therefore, the paragraph 7, which is a Supreme Court judgment on how the deprivation of liberty standards are used and interpreted, is of much more immediate significance to CQC, because we need to ensure that both our inspectors who are out inspecting are aware of what the Supreme Court has said in relation to the deprivation of liberty. but also we need to give some advice and guidance to providers so that they know how we are going to respond to the Supreme Court judgment. So what paragraph 7 is highlighting, Michael, is that we've considered that judgment, considered the detail of that judgment, and have issued advice for our own staff on how they should take that forward, and issued advice and guidance for providers so they're aware of where we're, how we're going to apply this. One of our members of staff, Rachel Griffiths, who's recently joined us to take on the role of looking after the mental capacity, deprivation of liberty standards work, I think has done a very good job in actually producing this guidance very quickly. This is a fast-moving issue. The Supreme Court really gave their advice on learning disability services, yet the vast majority of cases I think we will come across will be people who don't have capacity, who are older, and that capacity is a result of dementia, Alzheimer's, or other mental illnesses associated with old age. So we've had to interpret in our guidance to staff and providers what the Supreme Court determined in relation to services for people with learning disabilities. So an important judgment, I think, and those two things come in as close together. I think they were within this, the same working week. Important work there. Item 8 is Monitor's Accountability Report. I don't do this in writing, but we should do this. Monitor, I think, are the only second organisation to have been told by the National Audit Office that they present value for money. So it's no small achievement, I have to say, in the judgment that have been given. And I think it would be churlish of us not to actually congratulate Monitor and David Bennett and the team down there for what they've actually achieved. But the recommendation the Select Committee made in relation to Monitor and the relationship with CQC was that we should do some joint work in relation to how we work together, particularly where people are raising concerns about whether they understand what we do and what Monitor do. This is a helpful position in many respects because it allows us to write back to the Select Committee in terms of the joint work that we're doing, indeed just this week. And not driven by this, but I've had long conversations with David Bennett about how much more we can do together where there's a concern raised about a foundation trust where the issues may be about governance and quality, but we're not quite sure when the issue is raised, and it makes more sense for us to do any follow-up work jointly rather than separately, and we'll put arrangements in place to take that forward.
Because there is confusion about when it's Monitor or when it's CQC. I mean, does it happen if somebody comes to CQC and there are issues that are relevant to Monitor, would we automatically involve them and vice versa? You know, just if they come to us and it's a Monitor issue, do we, you know, automatically refer it? So it doesn't matter who they go to, that whoever receives the concern will then make sure that it's handed on to the relevant person. Otherwise, people just get kind of fobbed off. Yeah.
Yeah, no, it's a really important point, Kay, and Michael will probably add to this, but we had somebody who'd blown the whistle in relation to a foundation trust asked to meet with us, and Mike and myself met this individual, and as a result of the story that they told us, of their experience, this was more an issue they were raising around the governance and leadership of the organisation than about quality and safety, although there was an encroachment into quality and safety. I contacted David Bennett and wrote to him setting out some of the concerns, but this is happening on a number of occasions. Mike, do you want to add?
Just very briefly to add to that, yes, I think we have contact at a number of different levels between the acute policy team, for example, and their opposite numbers at Monitor, and I have links and regular discussions with Monitor, either about individual trusts, and certainly if we heard a new concern, and if it was a foundation trust, and if it was either about their finance or their leadership, then we would undoubtedly work with them.
And are we clear that our interfaces are robust? So if somebody comes to, say, the National Contact Centre Are we sure that that would get through to the right people? You know, they're not going to say, oh, well, that's monitor's job, you need to contact them. You know, that we actually do get, do you see what I mean?
My belief is that the National Contact Centre would firstly escalate it in my direction, and then we would decide from there.
I think this is work in progress, so I'm clear that at Mike and at Mike's level, at my level, if they come in, we have those conversations. And I'm clear, as Mike said, if they're escalated, we'll have those conversations. I think our ambition, though, Kay, and I think this might be behind your question, is that it doesn't have to come up to be exchanged. It's exchanged as a matter of routine. And I think we are in this stage, and I suspect this is what's behind this recommendation from the Select Committee about how we take this to scale rather than we actually rely on personal relationships between senior people. And I think at the minute, our performance on this will be variable. So I think locally, this will be being done because people will see it and they'll do it and they'll just get on and do it. And I think there are other cases where it probably does need to come up for the connections to be made. But our ambition should be, actually, this is just the way we do business. And I think we're getting closer to that. But your question, I think, was, can we be sure? And I think the answer is, we constantly need to be vigilant that we're getting this into the right place, and we've got more work to do.
Just on this, it seems to me what the Select Committee is asking or telling us to do is a really neat way forward, because actually we've got to meet with the people that complain to the Select Committee. So I presume this is the Foundation Trust Network and people like that, because actually they'll be talking about our people on the ground rather than you, and they'll be talking about monitor people on the ground. And so that, it seems to me, you know, both meeting those stakeholders is much more likely to lead to change. And so I think you know, going through those stakeholders, I think we will hear the real stuff that's happening. Right.
So we are in the process of taking that forward, and as I say, I had a long conversation with David about doing this, and I have to say it was a very easy conversation to have. So I think we're in a good place in relation to this. 9 and 10, Michael, I don't intend to present. It's an update in relation to Morecambe Bay. Dr. Kirkup has been given the Secretary of State's agreement to submit his report later in the year rather than sooner in the year. I think there's an awful lot of material, an awful lot of people want to speak to him, and in order to allow him to do that, he wants to take more time so he can actually get through the volume of both written material and interviews with the families, I think. So and just updating on that, and then we continue, as I've already inferred, to make appointments at in our frontline jobs, our frontline management jobs, as well as continuing some of the senior appointments. So I hope that helps, Dave.
Thank you very much, David. Just one point from me. You know, this overlap with Monitor, I think, is a very important issue, and obviously the Health Committee touched on it, as David mentioned. The Department of Health actually have Monitor's objectives, and the first of these is public sector providers are well led and provide high quality care to their patients. So right from the start, there is room for ambiguity about who's the regulator here. Also, I asked Claire if she could print out Monitor's new risk assessment framework, which has just been published. It is 97 pages long. It's actually longer than Mike's handbook on acute hospitals inspections. So, you know, one can see how important it is to make sure that we are coordinated with Monitor, especially as the Health Committee also referred to heavy-handed regulation. And, you know, it's clearly very important that that doesn't happen. But thank you very much, David. Perhaps we could now move on to Steve's report. I've actually asked, sorry, Lewis, sorry.
First of all, I think it's worth saying, it has been a tremendous amount of work to get out the signposting documents. I mean, it is an enormous suite of documents, which I've done my best to go through, including the appendices. But it is a fantastic achievement. If you think of the short amount of time that that's happened in, you know, it's less than a year, it's about 9 months since I first met David Pryor, and he was talking about ambitions for new methods and so on. And here is a key stage, really, in the establishment of those methods. I think it is a fantastic achievement, actually. And to have brought the staff and, to an extent, the public along, I think has been part of the achievement. One thing they did raise for me, though, is the fact that your method is only as good as its weakest component. And one of the problem components for us is the initial intelligence monitoring, where we're very reliant on what information is available rather than what information we'd like to know. And I think the handbooks bring that out, because the list of items on which the intelligence monitoring will be based is actually quite short in some areas. It's a little bit better for acute care, but it's pretty short when it comes to mental health and very short in social care. It's not so short in general practice, I don't think, but it is quite, it's sort of incoherent in the sense that it is a number of unconnected items which are meant to add up to what we know about general practice. Now, you know, that's all right as a starting point, because that is the situation, that's the information that's available to us. But part of the plan, presumably, will be over a period of time to build up a sort of data bank of the things that we really want to know. And I suppose it would be useful to know what is our plan. Do we have a plan to do that? Because new data collection across the health and social care system is no small challenge in itself. But that's what we're going to need if we're going to be able to do the intelligence monitoring part successfully. Can I make one separate point? And the thing that isn't in your chief executive report, David, and I've mentioned this before, actually. I know why it isn't, but are those tremendous rich reports that are sent to us weekly about cases which CQC is pursuing. And so these are cases where there may be warning notices or possibly prosecution taking place with providers. And a lot of them are care homes, but I'm bringing them up now because some of them aren't care homes, and so it is a broader issue. And every time I read that report, I'm slightly chilled by some of the things that are happening across the care system, and sort of heartened by the fact that they're being picked up and that something is happening about them. On the other hand, they are still happening, and we are very reliant on individual whistleblowers, it seems to me, when I read them, to know about them. And so my question is about those cases where CQC has taken quite decisive and sometimes quite strong action against providers, whether there is a way of making those things more public than we do at the moment, whether there's a way of learning from them, because there must be learning in those cases for them to have reached the point of, say, prosecution, and whether, and this is the ultimate question, I suppose, whether what comes out of those cases can be fed back into prevention, because in the end we want to be doing more than prosecuting, we want to be preventing as well.
David, if you could perhaps tackle Lewis's second point. On this absolutely crucial point about information, there is an agenda item later in the meeting when Emma Rourke is coming to talk about the CQC's knowledge and information strategy. And I wondered, Lewis, whether that's probably the point at which, you know, the first of your, you know, the first of the two important points should be tackled, because it is pivotal to this new knowledge framework that she's going to present. But David, on the issue of care homes and prosecutions.
So there's different ways we can go at this, and different ways we're attempting to go at this just at the minute, which doesn't see this report as a vehicle for that. So,
That wasn't a criticism of the
no. Yeah. No, how do we make it public, I think? Yeah, no, quite so. And so I think we've been working on an improved variation, an improved edition, if you wish, not variation, of the performance report, where one of the issues that non-executive members of the board have raised consistently, John Harwood in particular, has been a number of cases where we've had concerns but progress has not been made quickly enough, and this has often come in questions of enforcement action which hasn't led to improvements after 6 months, and even more so of those where there's been no improvements after 12 months or even longer. And so I think one of the ways we can come at this is by pulling out some of those individual cases in relation to that performance report. I think the second thing we've been doing, and Andrea's been leading on this, of some work in relation to a case called Orchid View, where I think we've talked about this publicly before, which was we'd engaged with a care home. It was a Southern Cross care home. The quality of care was very poor. Some residents had been abused. There's a serious case review which will be published. And one of the things that we've been doing differently in relation to that case is conducting a root cause analysis of what we did or didn't do in relation to our engagement with that case. A report has been prepared. What we intend to do is take that to the next meeting of the Audit and Risk Committee so they can scrutinise that in some detail, in much the same way that the last Audit and Risk Committee looked in some detail at the way the transformation programme was operating. And then from that committee, there can be a report here which gives the opportunity for some detailed scrutiny of those kind of cases. And it will allow us to do exactly what you're saying what is it from, what is the learning we can extract from the way that we've managed this case, and how can that learning then go back into either the design of our methodologies, the training of our staff, or the way that we make decisions. So I think that would be the first concrete example, I think, Lewis, of something that hasn't gone well from our perspective, that, well, quite frankly, we've not got it right, we've got it wrong, and what's the learning to take from that, and how do we do that? So I hope that's signalling a different way of actually extracting the learning, but also feeding it into the governance in an appropriate way. So I hope that gets us close to what's the learning to be extracted and what the individual cases are. The difficulty on, and again, this being a public board, is it worth just explaining, Michael, what I do on a Friday, which is I circulate a report to non-executive members of this board, which updates people on work that it is in progress where we've got concerns from a case being raised, and that might be a referral that's occurred that week, to actually a public resolution of an issue through a tribunal or a court case or a criminal conviction. And actually the awkwardness in reporting some of that publicly is about putting information which is still in either a criminal situation or there's a due process which is still in train that has not yet been completed into the public domain, as a distinct, I think, what you were asking for, which is where we know what the lessons are from those kind of cases, or there's an outcome from those cases, how do we make that public? So I think how we make the lessons public and the outcomes public is either through the performance report or through root cause analysis. And I'll continue to update members of the board on current work, which by definition is confidential, through the weekly report. I hope that makes sense.
Anna.
So, very good and important question from Lewis. So so you've answered for me part of it, David, but not the other part. So there's learning for us, but I think there's also a really important question as we develop the methodologies and the inspection regimes about the learning for the regulated communities, and what we can tell them ahead of finding issues in those locations about what they need to be paying particular attention to, because it has proven to be a problem in a number of instances in other in locations which we've had difficulties with. So there's something about feeding back to the community sort of what we've learned from the problems we've identified. And I'm not at all sure, and maybe we have a number of mechanisms for doing that, but I'm not really sure what they are. And I think it's a very important part of our programme as we learn, as we have a kind of better synthesised view about what it is that's happening in care homes or hospitals or GP surgeries, that we have that feedback loop very proactively to try to help them to prevent the issues, as well as for us to learn how better to identify them.
So I think there are two ways to do this. First, the root cause analysis report we've done on Orchid View will publish at the time it comes to the board. So it will be made public, so it will be there for people to look at. So this is about being open and transparent and people being able to look at that. And I think the way we draw out these lessons is in the State of Care report. That's what that is there to do, is to say what is our assessment on the quality and safety of care, what are the lessons learned and how do we draw that out. In terms of real time, the whole purpose of things coming to a public board meeting allows us to be, so where we published at that time and where we take root cause analysis reports, my ambition would be, having gone to the Audit and Risk Committee, it will then come here as a report, and any report that we do will be available for the public to actually have access to, so it's completely transparent.
So I don't want to make too much of this, but just to say that, I mean, I recognise that, but it requires people to come to us or our sources of information to find it. It's not. It's a pull approach to communicating those lessons to people, and I just wonder, in due course, and I don't think this is something immediately for now, whether there's something that we might think about doing in a more proactive fashion with, perhaps from the chief inspectors, kind of a quarterly lessons learnt this quarter to the kind of sectors that they're regulating. Or I don't know, I don't want to make it up here, but there's a question about, is there something we could do which would be a bit more about pushing stuff out to people?
The State of Care report is a push report, and I think Michael's point about 400 and odd people on our website. We have RSS feeds that go everywhere from these meetings, so I take the challenge around push, and it's a really, really important point that we'll give consideration to. But I do think we push stuff out, and we're trying not to hide stuff and actually learn. It's really important that we try and do this, and there'll be many, many different ways that we'll actually do this. We're keen and ambitious to do exactly that.
Okay, perhaps the last question today.
Just quickly, I mean, we are always being sort of pushed to go into the improvement space, okay? And that will, I think there'll always be pressure for that. And we've said that we encourage improvement, okay? So we're not an improvement agency. But I think that, and this is not just for us, but I really think that we need to have a sort of clear narrative for each sector as to what the kind of improvement methods journey is. You know, for example, there's the failure regime or success regime in hospitals, for example. So that's one aspect, if you like. And I think we have to be very clear that we don't overstep the mark and generate expectations that we can't fulfill. That doesn't mean that we don't do anything, but I think we need to be clear about what our role is in that, but also others as well, because I still think it's not that clear. So it's about sort of clarity for us and for others. Yeah.
Thank you very much. I think Kay's point is very important, and I think perhaps at the next board meeting, maybe the three chief inspectors could touch on Kay's issue, because obviously relevant to all of the three chief inspectors. If we can now go on to Steve's report, I've actually asked Steve and Mike to add a couple of things in their feedback. But in Steve's case, we've had this recent announcement by the government of this new access fund for GPs, and also a new program to ensure that I think it's the over 75s have much better access to a named GP. So I wondered if Steve, as well as giving his report, could touch on the implications of this recent government announcement, the implications for the CQC.
Thank you. Shall I address that first and then just want to highlight? So the report you're talking about is called Transforming Primary Care, of which we've had some input into, and we are quoted in the report. There are two aspects to the government's announcement of Monday. One is the Prime Minister's Challenge Fund, which I think is very significant. This is where money has been made available for innovation to try and improve access and the quality of care for patients. And I gather that around 250 applications were made. And instead of awarding a pot of money for 9 successful bids, there were far more that they have funded, and they include extending hours in areas of the country, using different ways of using Skype. And I think innovation should be welcomed, and at a time when lots of people are calling for investment, this is a way of investing, piloting, most importantly evaluating, and we would support that. The second part of the announcement was linked into the negotiations on the general practice GMS contract, and that's a way of trying to encourage more professionalism amongst my colleagues as GPs. And I think for a long time the criticism was that the quality outcomes framework, which was about scoring points for doing things, had removed some of the professional ethos and became more of a sort of bean counting type thing. And particularly as a practicing GP, we notice in February everybody is running around trying to tick the boxes to get the points, because the points are money and the money is staffing, and I was going to say happiness then, but it is at the moment, points mean prizes. And so 40% of the QOF points have been removed, and that also means that as a regulator, we have an important role to make sure that patients are receiving the care that they deserve, when it's not just about counting to make sure they've been ticked off in a box. So, and that's really important when you look at the vulnerable groups, because before the quality outcomes framework came in, and I think it was a really, really good invention when it first came in, but it's sort of overtaken by increasing the amount of income, proportion of income, so people focus on the points, not the humans sometimes, is that in the past, the more vulnerable groups weren't proactively called back to some surgeries consistently. So we have to make sure, and it's in our rating system, that the very vulnerable are included in the GP's daily work. But also by having a named GP, which is what we always used to have, and that's part of the contract, it does start to put back in some of the things that we lost 5 or 10 years ago. So actually the direction of travel, I think I personally would welcome, and we'll have to wait and see what the impact is. And we are mentioned in the paper around our role as ensuring quality. And I'm happy to take questions on that, although it's not my paper, obviously. On revalidation, just to pick up a few points, David is absolutely right. Professor Nigel Sparrow will be our responsible officer after discussion with David and Mike Richards. Nigel is a very, very senior GP. He's our senior GP advisor, and also is on the relevant general medical committees, and is the lead for the Royal College of GPs on revalidation. So he's one of the top few in the country who would really know this backwards. And it's for all GPs who are not practicing clinically but work for us. So that would include our Chief Inspector of Hospitals, but my personal revalidation goes through where my clinical practice is. So the number of doctors who this covers for us are tiny, but the workload is quite large. Whereas on nursing, when you start to look at inspectors, as David quite rightly said, the workload is likely to be quite large, and we'll need to work out the consequences for us. On information, clearly, as Lewis was raising the question earlier on, until we have care.data, we are really working with one arm behind our backs across general medical practice. We need consistent information for all practices, whereas it is inconsistent at the moment. So while we can develop the intelligent monitoring, it won't be as good as it is for the hospital side until we have care.data. And I'm hugely disappointed that it was held up, but I understand the reasons why it was. We started our work as a directorate on time last Tuesday, and we are recruiting well, and you wanted me to comment on a little bit more on the out-of-hours work, Chair. And we didn't put the figures into the paper because they change every day. As of last night, our Wave 1 out-of-hours were that we have inspected 31. 23 of those have been through our quality panels, remembering that we're probably 6 months to 9 months behind hospitals on our work. The lessons from hospitals and Mike's discussions about how you rate are very similar to in general medical practice, and we're learning from Mike and his team. In Wave 2, we've got 12 out-of-hours providers, which gives us a total of 42. And we plan to publish a report in June, which also looks back at the 2010 ministerial review of out-of-hours following the disastrous case in Cambridgeshire where the patient was killed by a doctor. We're going to review the recommendations that I made with David Collin-Tomey then, and that will be in June. We're planning to publish 12 reports on the 24th of April and another 19 in May. But again, learning from hospital care, we're not going to do that with an overarching report until we've got enough to make significant judgments. I would say, however, that the quality of care that we're seeing is generally good, and that's encouraging for me. And we've seen one particular area turn around dramatically following an intervention by CQC last year. So we're seeing that our work is having an effect on getting the organisations providing out-of-hours better. I want to make one final point, if that's okay, and that's about dentistry. Our Deputy Chief Inspector for Dentistry commences work on the 28th of this month, which is great. We're shortlisting on Thursday for a dental advisor, and we have one head of dental inspection in post. And so our plan, as you'll see in the paper, is that we're looking at inspecting probably around 10% of practices, although we're looking at the difference between 10 and 20% of practices each year. And we plan to bring our signposting document to this board in July. Thank you.
Thank you very much, Steve. Any questions? Anna.
Thanks. So on dentists, I mean, just some issues which really arise from local Health Watch and the Health Watch perspective generally. So I know we've got our hands incredibly full, but I have to say that emerging from local Health Watch are quite considerable concerns about dentistry in two areas: access and charges. So people still finding it difficult to get both good information and then good access to NHS dentists, and terminally confused about charges, and where they're clear about charges, making lots of decisions based on cost, which are not necessarily best decisions in terms of dental health. So we're getting reports from quite a few local health watch in this area, and what that kind of says to me, and this is to be tested and for the future, I think, but what that's saying to me is that we have two sets of issues, one of which could be explored perhaps in inspections, which is about the quality of information that dentists provide. So I mean, there's local health watchers saying that on the dentist's own websites there is poor information about whether or not, for instance, they're still open to NHS patients. And when they ring, it's wrong and they aren't, and so on. So there's something about testing the quality of the information. But what this also says to me is that actually this is an area where users of service are really working quite blind, and a situation in which actually ratings could be pretty helpful. And if you think about your own experience of, if you move home and you have to change dentists, it's a thing, isn't it? How do you find a dentist, and who do you ask about the best dentist in your area? And you go on kind of hearsay and popular opinion, rather as you would an estate agent. But it's kind of more important than that. And I just wonder whether we need to reflect on the decision about moving to ratings at some point, because I think quality of care is an issue which we feel as users very uncertain about. So I mean, just a set of issues to be further discussed, I think.
Thank you, and we can have a longer debate when we get to the signposting time and the work to that. But as you will recall, we reported here that CQC have visited every dental surgery in England, and the quality is satisfactory in over 95%. It does raise an issue, and it sort of links back to where Lewis was talking earlier on about intelligent monitoring. How do we use the data and the feedback from Healthwatch England to highlight that? It might well be that NHS Choices has an important role to play in publishing information about individual dental surgeries regarding access and charging. We're not the only player here. And there is a danger of us trying to do everything, and I think that would be very expensive and perhaps not a good value for money for us to try and do everything. In the past, PCTs had dental officers or leads in dentistry, and this is about contract management. And also the Dental Practice Board would inspect people and their mouths to make sure things were being done properly. Both of their systems are not anywhere near as good as they used to be. And I think we need to not pretend we're the answer to everything, and that's one of the problems we've got. What we are doing is developing our specialist dental team, and they should have the flexibility to intervene when Healthwatch England are raising important issues. So that's what we want to do. We're moving ahead on that, waiting for Janet to start in a couple of weeks' time. Thank you.
Okay.
Just a quick question on the revalidation issue. Is that are we considering revalidation for second opinion appointed doctors, SOADs, under the Mental Health Act? Because we have a kind of issue with attracting SOADs and responding on time. So I just wondered if that was linked into the revalidation work we're doing.
So thank you. We've had some discussion about that. Paul Elliott will lead on mental health. Most people who provide advice for us are active clinically, and as it stands currently, for most people, revalidation goes through their clinical organisation. There is a specific issue about SOADs, which we will be working on with Paul, and Paul will link into Nigel on that, and we will have responsibility overall for the contract management of that. But that was one of the first issues that was raised.
Right, thank you. Andrea.
Thank you very much, Chair. I'll just whiz through some highlights in the report and respond to some of the comments that have already been made. And thanks to Lewis for his reflection on the achievements that we've had in actually getting the provider handbooks out. And as I've said in the paper, I would particularly like to thank Rachel Dodgson and her team for all of the work they've done on the adult social care side, but everybody else that's been involved, and particularly the people involved in our co-production groups, both internally but externally, with people using services. Local Health Watch has been there, Anna, providers, carers, and some of our national partners, which I think is one of the ways that we're wanting to address how can we encourage that improvement, is by co-producing with all of those people what we think the characteristics of good and outstanding services look like, so that we can be clear about those expectations and hopefully inspire providers to reach those, but also to work with our national partners to identify some of the materials and resources that are available to support services to improve. So yesterday I was very pleased to speak at the launch of a toolkit that the College of Occupational Therapists have developed, for example, which is about living well through activity in care homes, and actually some really practical, helpful guidance and advice there, which from the development work that they've done, and we heard about yesterday at the launch, can make a real practical difference when it's implemented, and is consistent with some of the things that we're saying we're expecting to see in good and outstanding services in terms of people being supported to live meaningful lives in residential homes. So there's a variety of different ways that we're doing that. Lewis is absolutely right that the intelligent monitoring and the availability of information for adult social care is not as well developed in many different ways as it is for hospitals or indeed primary medical services. So again, that's an area that we're thinking about how do we work with others to get information out in a way that is helpful. And one of the things that I'm very mindful of is that Mike has found the staff survey, very, very powerful as a tool for the hospital regime. We don't have anything like that in adult social care. I mean, it would be a significant challenge, obviously, to have something like that across 25,000 locations. But, thinking through, well, how can we access the views of staff in a consistent way is something that I'm wanting to talk with Skills for Care and others about for the future. We started our Wave 1 inspections. We have had, and they are going ahead, and the quality assurance mechanisms have been established to review the reports that are coming out of those. Regional ones have already been held. The first national one is this week. We've had some teething problems, it's fair to say, in the Wave 1 inspections, particularly around the provider information return, which is a new element of what we're doing, asking providers to give, it's part of this trying to fill the gap in the information that we've got. We've been doing it electronically via a web form. I now say don't ever work with children, animals and IT because it has been a little tricky, and the team internally, but also working with partners in the provider world who have been very patient with us to actually get that information out. But it's been an important part of the evaluation is asking providers, how has this been for you, and sort of how long has it taken to complete the return? Did we ask the right questions? Have we asked questions that you didn't think were necessary? And given some of the difficulties that we've had, we're absolutely learning by doing, as David said earlier, because we have got a compare and contrast of some inspections that have happened without the provider information return and some that will happen with the provider information return. So we can, through this first wave, we can have some real practical focus on making it better both for wave 2 and then finally for the rollout from the 1st of October onwards. The other thing that I just wanted to highlight was the recruitment of our staff. As you know, we've got one remaining vacancy at Deputy Chief Inspector level. I'm very pleased to announce that we have now made an offer which has been accepted, and can announce today that that will be Sally Warren will come and join us. Sally is currently the Director of Programmes at Public Health England, previously worked at the Department of Health on the social care reform agenda, so brings with her a wealth of knowledge of our sector, and given that that post will also have the market oversight role in it, again, her policy background is going to be really, really very helpful. So we'll hopefully be making a formal announcement next week with a starting date, but it's great to know that we've got that appointment in the bag. And last but not least, we're going through the recruitment of the heads of inspection. We do have 11 out of 13 vacancies at the moment, so it's actually really very important for us, but we had a very, very good response, both good internal and external candidates, and we'll be very busy with those appointments over the next month or so. Thank you.
Thank you very much. Do colleagues, board members, have any questions for Andrea Kay?
Yep. Thanks. I mean, it's good to hear about all the progress. But I had quite a specific question in terms of the the consultation at the moment. Is there a particular plan in place to consult with people who use services and service user patient groups? Because I know that there's been a lot of co-production, but I'm thinking sort of broadening it out, particularly to people who are less heard. So I just wondered if what the plans were for that. Yeah.
Thank you very much. Chris Day, Director of Engagement, and his team have organised a host of regional consultation events, which is part of that activity, Kay, in terms of trying to make sure that we get out and about and speak to and raise the profile of the consultation with them. Information I'm sure is going out via Healthwatch as well. Particularly, I'm sure the ones that have been directly engaged with us will be doing that. And there are a number of speaking engagements and opportunities that I've got over the next 6 to 8 weeks, where, for example, Carers UK conference, I'll be speaking there, and speaking, that will be an audience full of people who will be able to provide undoubtedly their views on what we're proposing.
I mean, have you thought about engaging with the CQC's Speak Out network, which is a group was a network of lots of small user groups, which I think might be worth linking in with? Yeah.
If Chris hasn't got that already in the bag, then I'm sure we can do, Kay. Thank you.
Kay makes an important point, and I think what we'll do, Kay, is we'll make sure there's something on the internet that says these are the events, and we'll circulate those to board members as well in case you want to go to any of them. But we'll pick that up with Chris as well. And I think your point about the Speak Out network, it's interesting. I did an inspection the other Friday in a drug and alcohol project in Preston, and they were active in the Speak Out network, so they've got a kind of double engagement with us. So let's reinforce that point. Yeah, they are. Yeah.
Mike.
Thank you, Chair. Just on the separate point, Andrew, you mentioned the staff survey, and yes, we are very fortunate to have that in the hospital sector. Having said that, I am also finding an impression, at least, that the staff survey correlates very closely with focus groups that we then hold on site. Now, I think we ought to do some formal evaluation of that, because if we could demonstrate in the hospital sector that focus groups do tell us much the same, or corroborate each other, then that is a technique that possibly would be applicable in other sectors. So I think we need to think about how we would go about that form of evaluation.
Thank you very much, Mike. I mean, that's really helpful to know, and certainly one of the things that we already do is obviously speak to staff when we visit to do our inspections. In the domiciliary care agencies, we're piloting in Wave 1 questionnaires of staff in advance of the inspection, which is new too, and we've certainly had some responses to that, which is very encouraging. But you know, it'd be great to learn from your experience around that, and particularly in the larger residential homes, the focus groups may well be a helpful technique. So thank you.
Any other questions for Andrea? Okay, thank you very much. Mike, I've also made an additional request to Mike, because I think we all know that he's been on this, well, on this visit to this famous hospital, famous for its, I suppose, approach to lean and standardisation, and also Mike went with Jeremy Hunt, so you know there's a special significance to this trip. So I've asked Mike if, as well as his report, he could kindly give us, you know, a few minutes on again implications for the CQC, learnings from Virginia Mason, and so forth.
Thank you, Chair. If I just briefly do the routine stuff, then I'm very happy to come on to Virginia Mason. I mean, one of the big items of news for us this month, but it applies to all three of us, is that our new directorates have come into being. So with that, I now have 4 deputy chief inspectors and 8 heads of hospital inspection, and we are recruiting more heads of hospital inspection, and we've got some interims as well. But I think really importantly, what we're trying now to do is to create this as a new directorate, and we've had a whole directorate away day and then a senior team away day that followed on for that. And I think it's beginning to feel that it is an entity, which is good. And I think absolutely what came through from our whole directorate away day is the passion of staff to drive up quality through good inspection, and that is what gets them out of bed in the morning, and it is right throughout the directorate, and I'm sure it's true in other directorates as well. In terms of our inspections, we've now completed the inspection phase of both our Wave 1 and Wave 2 for acute hospitals, which means that we've done nearly a quarter of the acute hospitals in the country. Not all the reports are out from those yet, but because there's a sort of 2-month lag phase between the inspection and the report. Of course, the thing about this wave has been that we have been rating them as we go along. You'll remember that we rated 3 trusts in Wave 1. We rated them at the time, but we then held that back until we could compare them, and we published that with our Wave 1 report. Clearly, we are now sending out the ratings with the reports, and so the trusts get to see those ratings at the factual accuracy stage. I think this is sharpening us up, because it needs to, in terms of making sure that each of the ratings, and even for a single site trust, it means in effect that you're doing just about 40 ratings on the trust, and then there are summary ratings, and if it's a 2 or 3 site trust, it gets up to 120 or thereabouts. So it's a lot of ratings, and we have to be able to justify each one, which is driving us to think about the point that Lewis was raising earlier about how we standardise, we make sure what it is we're rating. I mean, if I just give one example, the issue when we're assessing outpatients, what proportion of patients are seen without their medical records being available? Now, which is, it impacts on patient safety potentially, it impacts on their experience of care, because sometimes they may be actually told, go away and come back next week. So we know that is not a good thing, but what we don't have across the country at the moment is a benchmark of what good looks like. I mean, 100% would be ideal, but is 99 or 98% acceptable? But is anything less than 90% or not? So we need to work with people to develop those benchmarks, and I don't think they exist anywhere at the moment in the NHS, but we'll work on that. Mental health and community services, again, we've now completed our first wave, which was very definitely a pilot wave, but we have, I think, been reassured that the broad methodology is working, and we've had the first of the quality summits for those, which again have gone well. And we're now moving into our next wave, which in terms of the acute hospitals, the thing that is new there, two most important things. One is that we are re-reviewing the sites that Sir Bruce Keogh reviewed last year to see if, particularly the ones that have been in special measures, whether they are ready to come out of special measures or not. And also we're starting on specialist trusts, children's trusts and orthopaedic trusts. Then finally, I would just like to add my thanks to the people, particularly working in the policy teams, Alex Bayliss, Sue McMillan, Amanda Hutchinson, for all their work on the provider handbooks. I think those really will take us an important step further, because what we're now really doing is linking the key lines of inquiry with the headings that we need to be looking at on inspection and the prompts that our inspectors will need, so that again that will drive the standardisation. So I think we know we've still got lots of challenges, but I think broadly speaking we're on track. Should we take questions on that and then go on to Virginia Mason?
Questions for Mike, Steve?
Yeah, thanks. It's sort of a question, but it's a sort of an amazed of Birmingham statement, really. I mean, I still find it quite amazing that hospitals haven't got electronic medical records. And having family who are in and out of hospitals quite frequently, as well as looking after a lot of patients, it just is amazing that the records are not in computer form, and that they get lost, because that increases the risk of clinical errors, including prescribing errors and transcription errors to us in general medical practice. And so the question is there any progress on hospitals coming up into the 21st century?
There is, but it's slow, I suppose, is the answer, Steve. And if one, to be honest, there are some that are considerably further ahead. A lot of them have partial electronic patient records, and then, you know, when the records are missing at an outpatient clinic, they rely on those partial records. It isn't satisfactory, and it is an area where primary care is undoubtedly ahead of the secondary sector.
Lewis.
Sorry to do this to you, but I've got a question which is slightly different from what you've just been talking about, but it is about, it's not about the US, but it is about Europe, because this morning the press is full of a story about this country having the smallest number of acute beds, or one of the lowest numbers of acute beds across Europe. Quotes quite a lot of figures, quite a lot of variation, slightly misses the point that the country with the lowest number of beds per head is actually Sweden, where most people think the healthcare is better than it is everywhere else. So that's what's behind my question. What are you finding, if anything, at this stage, about this very emotive issue of availability of beds and overall quality? And there's a sort of supplementary here, which is that when we talk about learning lessons, we are very often talking about learning lessons from other parts of the NHS. I know that we occasionally go to the US, and there are lessons there, but sometimes lessons on a grand scale are better learned by looking not within one system, where the amount of variation from one trust to another is quite small, actually, but to completely different systems like other parts of Europe. So although I've got some doubts about this report about number of beds being a marker of something on its own, there is a general question about whether we can learn from the sort of ecological variables of healthcare across Europe, and use that as well as, you know, the best practice that's happening in a particular English trust.
Thank you, Lewis, for that. And of course, we can even look to the United States, which is what I'm going to come on to in a minute. So far, yes, but if I'm prepared to go and look at others, where they're going to tell us things. I think the issue actually is how well we use our beds. And one of the things that we are looking at in each of our inspections is what is now commonly called flow, how patients go through the hospital. And this often shows up first in the A&E department, the 4-hour wait. It's not just that the A&E department is not working right, it's that people aren't being moved on through the hospital to the acute medical unit, the medical wards, and discharge. And how well is discharge planning being undertaken almost at the time of admission. So, and a lot of hospitals are tackling this, and some of the hospitals we've seen, rather than just open more beds in response to winter pressure, have been much more proactive in working with their CCGs, with social services, to say, no, we don't need to do that. What we need to do is to make sure that we get people through the hospital and out quicker. So I think we need to look at length of stay as well as numbers of beds, and we need to look at a number of markers. And one of the things that we're looking at when we're in a hospital is effectively how many people are in the wrong bed. So how many medical outliers are there on surgical wards? Because what that does, it impacts on cancelled operations. But it also means that there is a risk that the patient isn't getting the right care because the doctors and the nurses on that ward may not be appropriate to their needs. And you'll also have heard about sort of moves of patients at night, which we're all trying hard to reduce. So I think we don't need just to look at bed stock. That's quite easy to measure, but we need to look at how well they're used. And I think the Swedish healthcare system is worth us looking at. Again, I've certainly looked at it in the past from a cancer point of view. I haven't looked at it from a comprehensive point of view.
Michael, just to emphasise I think we can be held back at times in the debate about healthcare by these emotive issues like beds. And obviously beds are important, but they're not the only part. How many beds you need depends on what else you've got and all of those kind of things. I just wonder whether we will get to the point where we'll be able to move the argument on by showing that what really are the predictors of overall quality. And so my prediction is that they won't include the actual number of beds. They'll include the sort of thing you were talking about the use, comprehensiveness, the flow through the system. So it will be important that we get to the point where what you've just described is backed up by our actual findings, that we're able to show that the quality is linked to rather more subtle and nuanced approaches to healthcare.
No, I firmly believe that we will get to the point where we are able to say what are the predictors of quality, absolutely. And then I think that will be very helpful in the improvement agenda. I think that's one of our contributions to the improvement agenda, is being able to point that out. And so, I think it comes back to whether we have it in the state of care reports or an individual report by directorate, we can decide as the time goes on. But yes, we are looking for those themes the whole time. But we're still at quite an early phase of where we are, and particularly in being absolutely methodical at how we look across all trusts and gather the data.
Any other questions on Kate?
I always have questions. Well, the point I have is, in a way, it's not dissimilar to the one I asked Andrea, but it's about engaging clinicians. And I actually remember a tweet from Lewis that said that we need to show that we're on the side of good clinicians, which of course we do. But I also know, for example, I know that Deirdre Kelly did some work before she left, that frontline clinicians see CQC as a board level activity. And so I was just thinking, and I know that our specialist approach does involve more clinicians, and we've done quite a bit. But I suspect that the majority of clinicians still would feel that CQC is not particularly relevant to them, and it only becomes relevant when they've done something wrong. And I don't think that is the case or should be the case. And I just wondered, if you had any thoughts how we could, be more accessible to clinicians, engage clinicians. As you know, I use Twitter. And I often engage with clinicians on that, and it's really, really useful to have that kind of direct feedback, to hear what they're saying and have a discussion with them. Yeah.
I'm sure you'll get me onto Twitter sometime, Kay. I have been resisting up till now, but it's only a matter of time. I'm just not prepared to say how long that period of time is. But in terms of engaging clinicians, I think we are engaging clinicians a lot, both as our expert inspectors, if you like, but when we go into trusts, we are talking to a lot of clinicians. We have the formal focus groups with senior doctors, senior nurses, junior nurses, allied health professionals. So, I mean, we undoubtedly, even with those, typically, I suppose, by the time you've had 15, 20, 25 in each of those focus groups, you're getting to quite a number, and we bump into a whole lot as we go round. And we're speaking to the directors of the A&E service, the clinical directors, or of the maternity service, whatever. So we are engaging with really quite a large number, and sometimes they write to us in advance of an inspection if they've got a particular concern, and they do let us know. So but any other ways we can do it and do it effectively, really want to do that.
Yeah, and I guess it's also the feedback, seeing, you know, something happen from sort of engaging as well, and knowing what the sort of, this is partly the trust themselves, I guess, but you know, if you give your views and then you're not entirely sure what's happened as a result, that's one issue. And so the reports, for example.
And one of the things that we have already commented on, but I'm sure we will comment on more, is those trusts where there seems to be really good engagement between clinicians and management, and those where it is much less good, which may also bring me on to my next item.
Indeed, yeah.
Any other questions? Mike, your visit.
So Virginia Mason, thank you. I mean, I did spend 2.5 days in Seattle, it was about 3 weeks ago, with the Secretary of State, and he gave a major speech there about what he wanted to do to drive the patient safety agenda in this country with a Sign Up to Safety campaign. We visited 2 different healthcare facilities. One was called Group Health, the other Virginia Mason. Group Health was mainly actually probably of interest in terms of primary care, and I think that Steve may be visiting it again in due course. The thing that struck me there was that 75% of their patient contacts were either by telephone or email. And I think that will be somewhat different from this country, but I can leave our Chief Inspector for Primary Medical Services to comment on that. Virginia Mason is a medium-sized hospital. It's by this country's standards in terms of beds, it's quite a small hospital. It's got less than 400 beds. But I think they get people through the beds very quickly. It now has a major reputation for safety, but that wasn't always the case. So 14 years ago, my understanding is that it was a hospital in trouble, financial trouble, and it could have gone under. Gary Kaplan was appointed as the chief executive, and is undoubtedly credited with having turned the hospital round. Charismatic, strong leadership, but what has he done? Very early on, he took a controversial step, which was to take his 32 senior leaders within the organization to Toyota in Japan. And I think a lot of people said, what are you doing spending the money on that when A, we make cars in the United States, and B, why aren't you going to visit other hospitals? But he wanted to get people seeing a completely different system and taking a different approach, and the Toyota production system. And I think a thing they talk about a lot is any member of staff at Toyota can stop the line. If they see something going wrong, they can raise it, and until it's been resolved, the production line should cease. You know, there are times in healthcare where we ought to stop doing something until we have discovered whether it is serious enough that we really need to change completely, or on reflection, things can go on. And from Toyota, they've adopted Kaizen methodology, sort of intensive workshops, process mapping, which I think lots of places are now using, but I think a lot of places use it intermittently. They've now converted this into calling it the Virginia Mason production system, and it is deeply embedded in everything they do. So on this ward or that ward, they are trying something new, and they do it with a workshop, process mapping, and then see how they can improve it. Shortly into this improvement era, but well after they had started, they then had a very tragic case, the case of Mary McClinton, who was a lady who was having a relatively routine procedure done to treat an aneurysm radiologically, and unfortunately, instead of injecting the radiology contrast medium, they injected antiseptic, which made, first of all, her leg go gangrenous because it was being injected through the leg, and she died. I think the key factor here was they were completely open about it with their own staff, or emailed all staff, and publicly, and of course with Mary McClinton's family, and acknowledged what they had done wrong and resolved to learn from it. And a lot of the discussion we had when we were in Virginia Mason was the fact that almost certainly all healthcare facilities have Mary McClinton moments. It is just how you deal with them. Do you hush it up, or do you use it to drive change? And I think it was the fact that they were on this improvement journey at that time, and they've worked very closely with Mary McClinton's family, and they have awards in her name, and really this drive for safety and safety through openness, I suppose, is what is characteristic of the place. That means actually they report an awful lot of potential minor patient safety alerts, as they call them. It's a slightly different use of the term from our own. But they're proud of the fact that their staff are reporting 800 a month. Now that is probably 10 to 20 times the number that we would expect in an average hospital in this country, but they're very proud of that. And they do act on it, and they do feedback. What about outcomes? Well, I think the best evidence is their claims have reduced over a 10-year period, claims against the institution, by a factor of at least 3. And their insurance liability has gone down by a similar factor. Now that is at a time when I can't believe that the trend, I haven't looked it up, but in the States would have been in the other direction, I strongly suspect. And so really the question now is, what can we learn from this, and how can we promote this openness, this reporting culture, the absolute drive for safety and excellence in this country? And of course there are some places that are already doing a lot of this, and there are some hospitals that I've been to in this country which can describe their own Mary McClinton moments.
Thank you very much, Mike. Any thoughts?
Just one clarification. It's very interesting, Mike, actually. Can I ask just one point of clarification? When you talked about outcomes there, did you mean that they are safer, or that they are having to pay out less money when incidents occur?
They have fewer claims made against them, and they must be paying out less because the insurance companies are charging them less. So I don't think I know it more than that, but I can picture the graph that they showed us that shows that.
I didn't mean that to be a flippant question. I wondered whether they were just managing the complaints that and the incidents when they did happen, and therefore the resentment was less and the compensation was less.
Honest answer, yeah. I don't know. But that's something that we could follow up. And what I also should have said is that Gary Kaplan has already been working with a number of hospitals in this country, particularly in the northeast, and I'm hoping that we might be able to catch up with him again when he's next over for that.
Any other points?
I mean, I think I was going to ask Lewis's question as well. So I think it's important to sort of understand if the care was actually safer. But I'd also be interested in the the financial side of it, because the NHS spends an awful lot of money on defending litigation, and with this approach, early on, and would it actually save the NHS money, which then could be used, hopefully, on more, better patient care.
Again, could we get the details of the money? No. We were only there a short time. Are Virginia Mason themselves convinced that this is a cost-effective way of going about things? Absolutely, yes. So they do invest quite a lot in their safety team, in their Kaizen workshops and all of that. So it's not cost-free from the start, but I think they believe that both in terms of it's not just about insurance claims, it is length of stay, numbers of complications, and complications are very expensive. So that was less easy to demonstrate. What they could demonstrate was the claims data, but they believe that this undoubtedly has led to cost reductions for the hospital for care.
Thank you very much. I think, sorry, Anna.
Sorry, just a very quick one, probably, because I expect you don't know the answer. I'm just interested, those 800 reports, I'm just wondering if you've got any sense of the extent to which they were under the kind of serious and moderate categories that we're looking at in terms of duty of candour, or whether they extended beyond that.
My guess, and again, I didn't have time to look at them in detail, but my guess is they were actually reporting a lot of the so-called near misses and things that could have gone wrong but didn't actually gone wrong. So they probably wouldn't even be on our moderate level at the moment. They would be, it's something that might have gone wrong that was being picked up. And so, just to give one example, we went to a ward where they had a very good sort of electronic display of patients, not by name, I may say, but by bed number and a code. But then they were very keen on were they doing as much as they should to assess the risk of venous thromboembolism and then actually manage it properly. And you could see in real time exactly who had been properly assessed, what treatment they were on, and it flashed red if it hadn't yet been done. And I think, again, their view was we've got to move to real-time monitoring of these things so that, doing an audit 3 months behind time is better than nothing, but it's not what we should be doing, which is picking it up right now and saying this patient hasn't yet been assessed or treated, so what are we doing about it?
Mike, thank you very much. I think it sounds like an excellent idea to invite Gary Kaplan to one of our board meetings or a board dinner. The next item on the agenda is our thematic reviews, and I think we're going to divide this into two parts. One is, first of all, just to recognise the fact, which I must admit I wasn't 100% aware of, that the board has agreed to 5 thematic reviews already, and most of those are underway. There's one of them, which is end of life care, which really is the second item under this category of thematic reviews, where we're going to discuss and agree the scope of the review. But the first part of this agenda item is that, as colleagues remember, we had quite a discussion about what should be the thematic reviews for 2014-15, and obviously it was there were very interesting but different views around the table. So I think the board took the view of abdicating may not be quite the right term, but to ask David to take on this responsibility and recommend to the board the 2 additional long reviews that the CQC should be undertaking this year and the 4 shorter reviews. So perhaps David could just explain how he's reached this recommendation, and I think it's then for the board to agree that those reviews are the right additional reviews. And there's also an additional question about whether the review should be sponsored by one of the non-executive directors, and if so, and if the board agrees that should happen, we should perhaps do something like sort of an email volunteering process or something like that. But David, perhaps you can explain your choice.
Thank you, Michael. Thanks for the introduction. So there's nothing to add about how we find ourselves where we are in terms of the proposal. So I didn't make this decision personally. We sat down as an ET and we went through this, and it wasn't the kind of Brian Clough conversation where I allowed people to express their view and then I decided what we were going to do. So there was some genuine debate and conversation about this, and Malta was involved as well, given that it's his team that have been leading on this. But on the two big ones, we've gone, and these are on page 3 of the report. I'm not going to refer to the annexes in presenting it, Michael. And we've looked at the experience of older people and of people with diabetes. And the reason we've gone for these is we wanted to exploit really the position that CQC is in by having a view right across the system, across acute, community, primary and adult social care. And therefore the selection of the big topics, if I can use that phrase, was really about how we could comment on the system and the way that it operated on people's experience of services. And we've deliberately gone for a broad range, older people, who are the highest consumers of health and care, and therefore it will allow us to look pretty broadly at those issues. And then secondly, go for diabetes in the community, and how well people are supported to live with a long-term condition. And again, the rationale for this is as the healthcare system and the care system debate these issues about how in this part of the 22nd century we support people to live with and manage and reduce long-term conditions. It allows us to speak about not how the institutions and services themselves deliver care to those people, but how the system as a whole is delivering it. So we were effectively trying to set some balance, and it's an issue that board members, and Anna in particularly, has really contributed to the debate about how we go beyond just looking at institutions and services within institutions and look more broadly. So quite a deliberate attempt to get into that space and then generate intelligence and data that will inform the State of Care report for the year 14-15. So this time next year when we're looking at the State of Care report, we're generating intelligence about the operation of the system in addition to our normal regulatory activity which we'll have collected by this time. And I think this again picks up on some of these issues that Kay and Anna raised earlier about how you drive improvement, pull out messages, how we can actually contribute to encouraging improvement. So that was very much the thinking that sat behind those two big ones. On the the 4 others, no higher form of science about this effect, to be honest, Michael. DNA CPR, because it's an important issue, it speaks to the point around capacity and how systems are working to take these decisions and actually deal with these issues around capacity. Complaints and whistleblowing, it's not so much about how we will do it. Michael, you and I spoke earlier this week, and this isn't about how we're dealing with complaints, but how providers are dealing with complaints. Michael and myself were speaking about whether these reports are additive, not duplicative of other work that we're doing. So what we're aiming for here is to look at the way that providers are taking forward this work. Third one we went for was around the way that services involve people, and again it's a theme which I think has resonated through a number of our conversations this morning. Again, it's speaking to this point about can we say something about what good looks like and where we see good practice, and I think it also speaks to this point about And so what? Does it make a difference? Lewis's question to Mike about Virginia Mason about is a so what question in a sense. What's the evidence of what difference it's making? So allows us to comment on that. And then the issue about safety again. There is an issue. We continue in conversation with the Health Select Committee and Steve O'Dorrell in particular around the National Patient Safety, the National Reporting and Learning System. And this is one of the conversations I've been having with Simon Stevens about whether we can review whether we can play a stronger role in that as we move forward. And again, this will be a short piece of work which will allow us to explore that area in more detail. These four, Michael, are really designed to help us develop our inspection methodologies as well as say something about what we find through the thematic reviews. So unlike the other two, where I think we can speak about what the system, how the system is operating and whether it's effective, these four smaller pieces of work allow us to speak about what we find through the thematic reviews, but also help us to polish and develop our methodologies so we can improve our methodologies themselves. So that was very much the logic that led to the 2 and the 4.
Thanks, David. I thought we might just go around the table of the non-executives just to check that colleagues are content with this choice, and also obviously if anybody wants to volunteer on the spot for a particular review that they can. So Paul, what did you feel about this list?
I think what we said last time, we're just dealing with the 2 long ones. It's how we add to the knowledge that exists in these 2 areas. Because I think we said, not flippantly last time, that the answer to the question, the answer to both these questions is very badly. So in a sense, we know the answer to the questions, and then so how does the review add to the knowledge? And I think that it has to be using the knowledge that we have through inspections. So just thinking through about the one in integration. At some stage, there will be at some stage, hopefully quite soon, there'll be a location where we have an inspection of an adult social care system, an inspection of a GP system, and an inspection of a hospital. And it seems to me that is one of the places to start with old people there, so that we're basing it on our knowledge, and then and it seems to me very quickly, and this is the point you were making about the 4 shorter ones, very quickly we're going to have to start inspecting integration, because that very quickly is going to be, in fact it already exists. There are a number of organisations that are providing integrated services that are themselves integration of the services we look at. So I actually think these, providing we are sure that we are building on our knowledge, rather than just having another interesting analysis of these 2 things, because in effect, and I would very much the first day go to AIDS UK and Diabetes UK, because the amount of knowledge they have about how to answer these questions is enormous, and they can do sort of they've done the first 3 chapters of the work. And it said, so we would then go to them and say, thanks for those first 3 chapters. What do we learn? What can we add to the knowledge about this? And if we're Bagsing thing, since I'm becoming an older person, I have like declare an interest, and I'd like to be involved in the older person's one.
Thank you.
That's excellent. We have our first volunteer. Kay, what are your thoughts?
Firstly, I think the paper's very good. I've been on the CQC board for a while, and I've had a number of these reports, and this is by far the best one. I think Paul's comments are valid. Because the 2 larger ones are about kind of the system, and I guess that will change over time as we move as the system becomes more integrated. The shorter ones are, in a way, more specific and probably would hold good over time more. And I think that the topics that have been selected very much apply to our remit, and also how particularly issues that are really important to patients and the public. So I think they are really good. And the main point I was going to say really was that we need to be careful that I know we say all sectors, but we need to make sure that we do that, because there will be differences across in, say, mental health or learning disability, older people, which and that's not just difference in quality, but just actually difference in how things might be done, for example, in involvement. So so it's to make sure that we don't put too much emphasis on acute care when we're looking at these these sort of smaller topics, because in a way that can be quite more sexy, if you like, in a way, and it's easy for us to be overly focused on those. So we need to make sure that we do cover all the areas. And I mean, I would be very interested in the involvement one. So, yeah.
Excellent. Anna.
I'm really pleased to see this, David, and I think it's really helpful that you've got such a kind of reasoned case here. As Kay says, it's a good paper, and I absolutely recognise that that we could always add things and new ideas, and everyone's got their preferences, but actually there's a limited resource here and we need to focus it well, and this looks like a good list to me. So, and it will take, I think importantly, it will take us forward in terms of how we approach some of these integration issues, as Paul says, which we'll have to do more and more. So, in terms of our own methodologies, I think it'll be hugely helpful just dealing with some of these. And I take a great heart actually from reading the draft report of the themed inspections on children to adult transition services, which I think is really crunchy actually in terms of some of the things that it comes up with. And I if we can do that in some of these other reports, then I think that will be a very useful contribution. And I'll do whatever you want me to do. I mean, yeah. so fit me in where it seems appropriate.
Thank you. Lewis.
Well, I thought this was much better. It's obviously more strategic. I suppose that was the fundamental area of unease, I think, last time, that it seemed it was just a little bit thrown together and didn't add up to something beyond the individual topics. Here, I think that's different. I think it does seem like there's a reason why these topics fit together. They're sort of brought together by certain characteristics. The key one is this issue of being multi-agency, the sort of cross-cutting element. What can this form of investigation do that our individual inspectorates might not be able to do? I think the topics, certainly the two main ones, do take that approach. It also allows us to stray a little bit off the inspection methodology, so we can be more concerned about the values, for example, which some of the topics are. Some of the individual topics, I would say, and move towards that element of just a greater focus on what patients or services tell us. Of course, the inspections are about that too, but they're about a lot of other things, whereas these topics can be about that issue to a much greater extent. So I think these have been well chosen. But I do have two comments about the choices. I agree with Anna that we can't really spend another meeting going over the individuals, but I do think there are two comments come out of this for me. One is, of course, the one about the comment about IAPT. So just to remind people, IAPT is the biggest policy in mental health of the last 5 or 6 years, following the community care reforms of the previous 5. And so it's had a lot of investment, a high public profile, and there are growing questions from the field about how it is working for patients. I suppose I'm happy to go along with the choices here, but I'm not absolutely convinced of our reasons for not doing it. The reasons are, first of all, that we've got the mental health crisis care topic already. IAPT has nothing to do with mental health crisis care. We've got another reason, I think, is the let me just remind myself of the reasons. Excuse me for reading the appendix that you didn't want us to mention. Oh yes, another one is the other evaluations of IAPT are being undertaken, but that is the point. The evaluations that are being undertaken are largely being conducted by the people who are running IAPT, and that isn't the evaluation that patients need to see. They need to see an evaluation from their perspective. So the patient complaints that referrals take too long, that the system is meant to resolve that problem. The issue that patients are sometimes excluded from a service which should be inclusive, that is not going to be addressed by any of the evaluations I know about. So I don't agree that we've got good reasons for not including IAPT, except possibly the other one. And the third reason that's given here is that a lot of IAPT services are not required to register. Now this is an extraordinary anomaly, if true, that the main flagship service across mental health services doesn't have to register with CQC because, as I understand it, of a technicality of what sort of clinicians are in overall charge, which is that they are services overseen by clinical psychologists. And because they're not registered, is that right, David? They're not. I mean, we do need to relive the whole of that. Now, if that's correct, if that particular anomaly has got in the way of doing a thematic review on this crucial issue, then we've got to go from here and say, what are we going to do to change that situation? It isn't really an acceptable position where we can't look at, it's not one of the core services for mental health inspections either, we can't do much on IAPT because of a quirk of registration law. That will have to be changed. And so in agreeing to this group of topics, could I also make a request that we solve that problem of IAPT registration, which is getting in the way of understanding patient experience of a key service?
David.
Well, Michael, why don't I have some conversations with Lewis, and if we involve Paul, Mike, in that conversation about what within our mainstream inspections we can do. There's a primary care dimension to some of this as well, and I think Steve's signalling to come in as well. So why don't we look at that? It wasn't that I didn't want to look at these, it was just that Michael was far more diplomatic than I in his introduction, but we've been, the board wanted to select, and then we came be and go away and make a decision, and so having selected what our programme is for thematics, and if we can lock that down, then I think your challenge back to us about what are we doing about what is a huge now service which is reaching lots of people, about whether it's safe and it's delivering a quality service to people, then let's come back to that. Let us think further about this issue about what our regulatory reach is and if there's a solution to that. So on both of those, why don't we get a date and have a separate conversation, and perhaps get Paul to come and join us, and we'll see what we can do in relation to it. And if somebody from Steve's team needs to join us on that, then let's look at how we can do that. So I think we can actually reach into that area without necessarily doing a thematic review. And as we mature our approach to this, and we've got the resource coming on stream to do this work over the next period, then when we come back to look at these topics again, I think one of the issues we were saying is, should we just roll these topics forward, or might there be other priorities that we've got next time we sit down to look at the programme for the year? So I think we should carry these forward, but there shouldn't be a guarantee that we're going to do these that didn't get done next year, because there might be other priority topics. This point about how much more we're going to reach for integration might be a stronger theme next year. So let's look at how we roll these forward, but in the meantime, let's look at what more we can do in relation to IAPT. So you and I have got a similar journey with the etiology of this policy, Lewis, and let's take that away and look at it.
Steve.
Thank you, and apologies to David because I haven't had a chance to feed back yet, but I've already had a meeting with Paul Elliott, it's following our executive team meeting, but it was a preliminary meeting. I need to declare a conflict of interest, a past conflict of interest, in that I was part of the research team and technically continue to be with Richard Layard around IAPT, and we're party to to the lobbying that we both did very hard to get this in all three party political manifestos before the last election. So I believe in the concept, so there is a conflict. I see this as a primary care stroke mental health issue because it's actually what happens in primary care. And as a GP, I see the variation in both access and in quality. And so what we were talking about doing with Paul was, in our visits to CCGs, looking specifically at the interface between primary care and mental health, and that includes IAPT, because it's the single most negative thing that comes back in feedback when we talk to GPs about access. It's the mental health part of that which is the issue. I'll be very happy to include you and others in the next meeting, but it was because this hadn't been chosen, I thought we could do that. My second point, just to support Paul, is that leading on integration, both of the two major themes here helped me enormously in taking my agenda forward, and that's why I gave it the support. But I share with you the concern about IAPT. What we will do is look at some of the CCG areas that we go into. We will produce a report. I'm happy to produce a report for the board on that, and that might feed into the choice of thematic reviews for the following year.
Thank you. Right, the final item under thematic reviews is for the board to agree whether the scope of the thematic review on end-of-life care is appropriate. Now, there's quite a long paper here. I think it is worth pointing out that the Liverpool Care Pathway Review actually asked the CQC to do three things. One is to help define what good quality actually is in end-of-life care. It also said, recommendation 40, that end-of-life care should be incorporated urgently into the hospital inspection programme, and of course that's exactly what Mike has done. And in fact these sort of issues are interrelated, because there are already, I think, evidence, Mike, of some very good practice, like in Salford. There are actually now bereavement nurses, according to the inspection report, which sounds like an absolutely admirable idea. The final thing was they did actually ask the CQC to carry out a thematic review within the next 12 months of, I'm just reading from their recommendations, of how dying patients are treated across various settings, from acute hospitals to nursing and care homes, as well as in hospitals and the community. So I think that the only question here is whether the board have any issues with the scope, or whether it's fine to go ahead on the basis as defined, outlined, described in this paper. Andrea.
It's just one small point, Chair, and apologies for colleagues for not raising it previously. But when we're talking about the questions that we want to answer on page 9, which is about what good practice can others learn at a local level, and what action can national and local stakeholders take to address the inequalities that we might see, there's two aspects to the external stakeholder list on page 13 that I think that it would be important to address to help us, which is that absolutely key to making a difference is what happens with the workforce. And what we've not identified really in terms of the external stakeholders are the key people who I think could help us around the workforce. So Health Education England and Skills for Care, to take both the health and the social care perspective, but also the employers' organisations, again across health and social care. And then the second point is that we've identified NHS Improving Quality, which is obviously the improvement agency to support the health service, and declaring my interest as the former Chief Executive, but I think we should also include the Social Care Institute for Excellence to pick up the social care side of things as well. So it's just those 2 points. As I say, apologies for not raising previously.
Thank you. Lewis.
Yeah, can I just say, I think this is exactly the kind of thing that CQC should do. It's the best kind of work that we can do, because it is about sometimes marginalised groups at a particularly vulnerable time, and that really ought to be at the heart of CQC. It's one of the most important things that we can do. So I think this is a really important and very good, excellent piece of work. At least it has the potential to be that, I should say. Can I ask a couple of questions about it? And I just was very keen at on the broad scope of what was meant by people who were vulnerable. and the reference to people with dementia as a kind of vulnerability in itself. And I just want to check that, that the kind of people I've got in mind are also what this description has in mind. So there are some people who get to the end of life who it's quite difficult to define exactly what their condition now is, but it includes a degree of dementia, and it includes frailty, and it often leads to breathing difficulties and occasional hospital admissions. There's a very familiar sort of pattern here, and I just want to check that sort of frailty group is part of what this will be about. That's a slightly different way of looking at the vulnerability. I want to check as well that the information that is collected will come from people relatives who've been through the experience of having somebody die. That's referenced in the full description of the work. It isn't actually mentioned in the summary. I just wanted to check that it is part of the work, because those people have a lot to say about the experience they've had previously. And then thirdly, I just wanted to check that we'll have that what we are looking for will be expressed in the most sort of human terms. And I say that because there is something slightly odd about the way that we always talk about personalised care. We have a particular way of talking about personalised care, which is the most impersonal possible way of describing it. And a good example of that is the nice. There's nothing wrong with it. Nothing wrong with nice. And it's description of end-of-life care, but it isn't what you'd want the care to be judged against. So it's all about things happening in a timely way, holistic assessments, and all that sort of jargon, which is all correct. But in the end, this needs to be turned into individual human experience and the dignity of people's final days. And so I just want to make sure that is what we are. That those in the end are the kind of criteria or standards we'll be looking for.
Mike.
Lewis seems to have been looking in my direction for some of those questions, partly because, as you all will know, that I used to be the National Clinical Director for end-of-life care. I think the answer is yes, we will undoubtedly look at frailty, and indeed there's been a lot of work done on the different trajectories in the last months and years of life of patients with frailty, for example, as opposed to those with cancer or those with other long-term conditions, and we certainly want to do that. I think there are huge numbers of inequalities in end-of-life care. There are the inequalities by geography, and we know that from the survey of bereaved relatives, which again I'll declare an interest I helped us to set up, which is now run through the Office for National Statistics, where basically they write to the person who registered the death, and we get about a 40% response rate from that, asking the person, whoever registered the death, if you're not the most appropriate person to answer these questions, please pass it on. And we get a lot of information about care in the last 3 months of life, the last 2 days of life. But what we also find is that there are huge variations by big geographical areas across the country. Unfortunately, it wasn't a large enough scale survey to be able to get down to the individual health authority or local authority or CCG, but it nonetheless, at the sort of level of population of 1 million here or 1 million there are big differences. So there's that geographical one that is undoubtedly inequality by diagnosis. Cancer patients get a better deal than other people. There's inequality by where you happen to be, with hospitals doing undoubtedly the worst, and care homes and home doing a whole lot better. Yes, hospices do best, but if they didn't, I think we would all be worried. But then on top of that, what's much less known about is various specific vulnerable groups, because the data aren't collected well enough. And I think that will be one of our biggest challenges here. How do we get information on homeless people? How do we get information on even people with dementia? But I hope we will be able to do that, because I think, as we've outlined before, what this will then do is help us all in our inspections. So it'll sharpen our inspections when we get to, whether it's hospitals, primary care, social care, the lot.
Lewis, I don't want to volunteer anybody, but your passion for this subject, would you like to be the... No, and it really did come across in what you said. Would you Well, you can obviously, we do need a named non-executive, so if you're happy to be the named non-executive, that would be really good. Thank you very much. Right, well, this takes us to the coffee break. I think the suggestion is literally that we go and get another cup of coffee and then restart at 11:05, if that's okay with colleagues. So. You can see how I'm a novice at this. We're now going to go through the second half of the agenda, or at least it's the last third of the agenda, I suppose. And we're going to start with item 9, where Emma is going to update us on the progress the CQC is making on its knowledge and intelligence framework. And I mentioned to Emma that Lewis had raised a very important point earlier, and we thought it was appropriate to tackle it during this particular session, of the CQC's ability to really understand adult social care and primary care, where the amount of information is much sparser, and the CQC really does need a strategy to be able to gather, or to identify and gather the information it needs. So it'd be very good if you could cover that as well as giving us the update on the framework. Thank you.
Okay, thank you very much and good morning. So by way of introduction and background to the strategic framework, obviously you're very familiar with our corporate strategy and our ambitions, which include better information for inspection, developing a more authoritative voice on health and social care. One of the most vital ingredients to us succeeding in those is being intelligence-driven, as we describe it. And the strategic framework is one of the most important for us steps in becoming more intelligence-driven. The way we've tackled what intelligence-driven looks like and what it means for us and where we need to get to is described in the issue tree in the document. The issue tree has identified for us sort of generally 3 areas of where we feel we need to focus our attention. As well as the new strategy, we also have a new operating model that is emerging, and a cultural shift that's required in the organisation to underpin the delivery of our strategic objectives and to become intelligence-led. The conversion that we've talked about, for example, in our operational colleagues, also applies to our analytical colleagues as well. So it's whole-scale transformation in terms of the way that we create, value, and exploit the information that we have, that we want to source from others, to become intelligence-driven. Because of our new strategy, because of our new structure and our new operating model, we felt that it was the right time to refresh the structure around knowledge and intelligence. And so we've built on the issues emerging from the issue tree to create some initial narrative around our ambition. So this narrative is intended, as is detailed in the paper, is intended to give colleagues, both internally and externally, a vision that they can start to apply to programs which deliver the detail that will have the impact. So this is to support individuals to engage with the ambition, to better understand in reality what intelligence-driven means, and to start to plan for themselves, being cognizant of the 3 corporate themes about how they can be translated both at a high level but in a more detailed day-to-day activity. So the main elements, as I've said, are the issue tree, and finally the 5 work streams that we are seeking to employ to deliver the granularity that this programme now seeks. The 5 work streams will cover what we believe are the full breadth, the dimensions of knowledge and intelligence, and to respond to Michael and Lewis's point about areas where we are less data rich, like adult social care and primary care. I see that broadly sitting across both quantitative and qualitative. For the next board meeting, we're seeking to bring a paper on our adult social care strategy as an action from the previous board. We've been doing quite a lot of work under the auspices of the National Information Board to develop better information for adult social care. And we, as part of that, it is making sure that when we are driving better information, that has value, that is cognizant of any burden, that we apply a value test to any new information we ask of providers. But we also make much better, more intelligent use of qualitative information that is out there. And the reason why we've separated the two out is that we believe they require very different tactics, very different solutions, very different types of expertise to fully exploit this information. But that the framework as a whole, guided by this knowledge and information work stream we have as part of our transformation programme, will ensure that the two work streams do not become divergent, that there is a cohesiveness at sector level that exploits both types of information. Is that all right? As by way of introduction, I'm happy to pause and take questions.
That's very good. Thank you, Emma. Questions? Okay.
Yep. Thanks, Emma. Obviously, kind of really crucial that we get this right. So it sounds great. I mean, it's not the first time I've raised this, but just I'm always kind of concerned about the weight that might be given to kind of, if you like, the qualitative stuff, particularly the voice of people who use services. You know, because it you know, oh, it's anecdotal, or you know, so it's. But sometimes within that you get the nugget that actually, yes, particularly if you haven't got other information, it could actually be, you know, fundamental to, yes, you know, it could be indicating a real problem with a service. I mean, we may not know that. So it's really sort of how can we, you know, make sure that the qualitative stuff is captured and used in the best way and not sort of seen as the sort of second-class cousin to sort of quantitative, you know, hard data. And the other question is, in terms of our inspectors, you know, how are they going to be sort of engaged in this so that what we actually, you know, deliver meets their needs, and also the National Contact Centre as well, because you know, obviously that's crucial, because if they don't find it useful or can't use it, then you know, it fails really. So, you know, just how you're going to build that into the strategy. Yeah. Okay.
Yeah.
So just on the first of those points, and I should sort of start by saying I read the cover paper and I thought, oh my goodness, what is this going to be about? And then I got to the tree and I thought, oh, that's great. I get it. It gives me a really good way to think about it. So I've found that really helpful. And so I'm kind of focusing on that second box down, sort of on the third layer of the tree. How can we secure access to agreed and needed? And I think the needed is all about the proactive kind of new information that we don't have or, yes, wouldn't be available, which is really important, directly from people. And so my supplementary to Kay's is how far you've got down the path of thinking about what the existing sources of that information are extra to those that are in the system. So, you know, the Information Board and HSCIC and other people will provide system information, but we know that there's an awful lot of the service user organisations, for instance, do their own survey work, and there's something about working with them to help them to shape, where appropriate, their surveys to pick up the kind of information which we need. We at Healthwatch England will be doing data collection from, in addition to the proactive stuff that Local Healthwatch give us, we'll be doing sort of quarterly data returns from Local Healthwatch. So there's something about making sure that we too are asking of them the right kind of questions to get you. So there's a both an engagement with all of those service user-facing bodies to collect what they've got, but also to help in the same way to help shape what they might do going forward, which I think is hugely important and outside the system.
In addition to that, I mean, I think this is, in a sense, one of the reasons we're all here is around mid-staffs. Literally why some of us are here is around mid-staffs. And in a sense, there, official data lost and soft data won. And this, I just think it's very, very important to remember that in these discussions. So it's in a sense the mandate for soft data in these sorts of discussions is now very, very powerful and very hard. And so in a sense, one of the things I think probably the three of us are saying to you is there needs to be sort of a militant restlessness in going out and searching for that soft data, because it will contain things that are potentially actually crucial to our mission. Yes. And we don't know where it is.
Yes.
And so there's a risk here. Right?
Mm-hmm.
So in a sense, the knowledge I think probably a grander way of saying it is that you referred to data outside the system. Actually, that's because we limit the notion of the system. There is data inside the system if you include patients in the system. Mm-hmm. And under those circumstances, how we get hold of that, as I say, I just think it needs to be a restlessness all the time. Yes. And knowing that what we've got is incomplete, and therefore we need to find other ways of getting it.
Emma, if you'd like to respond.
Thank you. In terms of qualitative information, and specifically the voice of people who use services, I think it's fair to say that historically CQC has not invested sufficiently in this. So as part of our restructure, as part of the transformation programme, we have dedicated an entire function within intelligence to qualitative information, and that is split into surveys, qualitative innovation, qualitative analysis and local intelligence analysis. The ambition being that we, alongside our new strategy, we have a much better organised, disciplined sense of what information is out there, what has value, and we're able to segment that information both by sector, both by people who use services as well. We find that a lot of our sources don't usefully segment population groups. So one of the things that we're working with engagement on at the moment is how we can get a better sense of who we hear from and who we don't, and the degree of utility in mechanisms such as our intelligent monitoring model and our data pack these various information flows have. It's important for us, as I think it is in the document, not to see more data as better data, that we need to be quite discerning, both in terms of bringing in both qualitative and quantitative information. So we do want to tackle the question about where is the data we need, and who are we engaging with in a very sort of considered and methodical way. So there, I believe we have the form that follows, the function that we believe we need, and the qualitative strategy that will emerge from this will provide that those individuals with direction to deliver what's required. Those individuals that are currently in post, we're undertaking a recruitment exercise at the moment. I do think we do have militant restlessness. I love that phrase, and I think that colleagues already working in that environment will really heavily subscribe to that language. If I could move on to the where is the data we need, which I think was Kay's second question.
Yeah, and it was about to make sure it's useful and usable by the front line, if you like. Yeah, inspectors and others.
Yes.
Yeah.
So in terms of the data that our inspectors need, currently is made visible through the data or the information packs. through inspections. We're at different stages at different sectors. As you know, we've got a slightly different timeline for different sectors. As part of the background to the Knowledge and Intelligence Strategic Framework, colleagues in information services and IT did do some interviews with inspectors to better understand what it is their needs were. So we've got, I think, the beginnings of a better understanding in terms of what technology, in order to support better mobile working, is, how our inspectors better want to engage with how they receive information and how they utilise it. In terms of content, we're on quite a long journey, I think. In terms of content. We have made, I think, very good progress in the acute sector by setting out an initial framework and architecture for data packs. We, as you know, are procuring for some additional support in that space that will cover both mental health, learning disabilities, community and acute, to take us to a much better place that is much more supportive to the workflow of an inspector on an inspection, is much more intuitive to what an inspector needs. For adult social care and primary care, we're launching the information data packs this week to support the pilot inspections, and we will be evaluating those as they go, and that will evaluate both the way in which the information is presented as well as the content. So I think, whilst we cannot yet claim to be giving the inspectors what they need and when they need it, I think we're on a much clearer and positive trajectory.
Mike.
Can I just come in on this point about the inspectors on the ground? Because I think there is a huge amount we need to do to skill them up to use the data that Emma will provide. And the line I've been taking is that we need the data for at least 3 different reasons. One is for planning our inspections, one is for probing when we're doing an inspection, and the third is judgment. So there are relatively few of the data sets that are sufficiently robust that in themselves we use them for judgment. I think the staff survey is one of those. I think the CQC inpatient survey is one of those, because we know the methodology, we know it's robust, and the samples are large and stable. There's a whole lot of other information which is really useful either for planning or for probing. You can't really plan an inspection of a maternity unit unless you know how many children are being born there each year. Is it 300 in one place and is it 8,000 in another? You need to know that. Something that a lot of hospitals don't know is how many people die in their hospital. In fact, it's a question I often ask chief executives. You know, and the best ones know precisely, but others do not. And how can they be planning a service if they don't know how many people died there? And as somebody pointed out to me, they know about the number of births because they get paid per birth. So you know, that's me back on my hobby horse of end-of-life care. But equally for probing, the things like the friends and family test are very useful for that. You can ask questions, and you can, but we also need to be sophisticated in how we use it. I've seen a hospital where the responses that have come into CQC about that hospital were almost universally negative. I think it's in one of our reports, I can't now remember which one it is, but 19 out of 21 comments had been adverse. For the same hospital in the same period, the comments to NHS Choices have been almost universally positive. So we do need to have that sophistication to be able to know which data sets we can use for which purposes. And I think even when we've got the data, the big task is making people use it sensibly.
Lewis.
Thanks. Sorry if this sounds like I'm repeating myself. I just need to be certain I know the answer to the question that we started with. So what I mean, I think when you look at the lists of variables that we start with for the intelligent monitoring, there is an obvious mismatch between the length of the intelligent monitoring variables and the number of key lines of inquiry. So I don't know how the inspectors will deal with the very large number of key lines of inquiry. There are just so many. And I suppose that reflects the fact that we don't yet know what the data the actual figures are really telling us. And so it's rebalancing those two things, so that I think this takes me to what, Mike, you were giving as the sort of second use of the information, where the inspectors will be able to say, we would like to know how you explain this particular finding in our intelligent monitoring. And at the moment, it doesn't feel that we're very close to that position. And so thinking of how we get there, I just want to check that. So what I was getting at this morning, when you weren't here, Emma, was whether recognising the gaps in the available data, because we're very limited by what's available at the moment, but recognising the gaps in what's available, we're able to say as a matter of strategy that over the next, I don't know, 3 years, might be less, might be 1 year, what we really want to know to allow the key lines of inquiry to be more focused is are the following 5 things, or 10, whatever it is. And so those are the things that we would like to know, and those things are not available at the moment. But for us to do our job properly, they need to be available. So we go to, whether it's the Department of Health or NHS England, the trusts themselves, and say, if we're to do our job properly, you must provide this information. And some of it you don't even collect at the moment. Some of it you do, and it's not very good. But from a strategic point of view, we set ourselves a task of transforming the intelligent monitoring into a coherent and valid set of variables over a defined period, and then check progress, and then we put the onus on provider organisations, on NHS England itself, to make sure that happens, because they've got to make sure we can do our job. And on the issue of complaints, I would include the complaints in that. I like the idea of restlessness, but it's not enough. As I'm sure you know, in the end, this is where I'm repeating. I do apologise for repeating myself, but I do think we have a tremendous opportunity to lead the way on the science of complaints. And probably the first thing we would do is stop calling them complaints, because I don't think it is just about complaints. The intelligence that's out there is more than that. But it is partly about understanding who doesn't provide information, which patients, which families don't ever provide feedback, and that's quite a large number, and what they really feel about the service that they get, because that information is absolutely crucial. And it's the way that opinion pollsters, they adjust all their findings according to who they didn't talk to, and in a way that we need to be able to do something that's a little bit like that. I was slightly sorry that that report this week was called "More Complaints, Please." Is that what it was called? That wasn't your report, though.
No, it's the SLT.
No, but it was sort of it was a jolly title. But on the other hand, it isn't more complaints that are needed. It's better information that isn't a complaint. And once we've got that, then we've got the basis of what I think of as a science, which nobody else has at the moment. And it does include catching those nuggets, but it also means balancing it against people who don't have a voice in the system at the moment. So I suppose that's where I get to. And is that what you're describing, that plan over a short period of years to get us to that point of the balancing of data versus key lines of inquiry?
Yes, I think part of it is in terms of the information driving key lines of inquiry, or at least supporting the development of key lines of inquiry, is probably a better way of describing it, is in part the way that we present the information. So in terms of currently the data packs, should, I think, be encouraging that relationship better than it currently does. So our next iteration will promote the use of intelligent monitoring through to developing the lines of inquiry, whilst we continue to evaluate the intelligent monitoring in its own right. Those two things have to happen together. In terms of data development, we have for some time now had separate sector level data strategies, as we call them, that have articulated what do we feel we need to know in order to regulate well against what we actually have. And those have evolved through the work that we've done on the data roadmap, with the National Information Board, and that will form the basis of what we present to you next month for adult social care. And it's been the way that we have influenced the Information Centre and other colleagues to collect or adjust information collections previously. The National Information Board for us has been a really helpful vehicle to expedite some of that. And the last meeting we did agree some priorities as a result of the work that colleagues like Tom Ward have done on the data roadmap. So I think that's quite a promising vehicle and underpins the trajectory that we're going to. On your final point about the complaints and knowing who doesn't provide feedback, I think that's really important for us, and that's one of the reasons why we need to think about how we segment people who use services to understand better how we can be more proactive and how we can target individuals. So at the moment, we do obtain the majority of our information through mechanisms where it's up to the individual to link in. So if they want to put information on a website, for example, or on our website, then they take themselves there and they do that. And I think we do need to balance that with a much more proactive attempt for particular groups in the community that we need to hear from more.
Emma, thank you very much. I don't know if colleagues have any more. Eileen.
Well, I just wanted to add something to the mention of complaints. I think it's an important week to do so. And Emma rightly talks about how we gather information about complaints and concerns externally, but I think it's also important to note that under Michael's stewardship we are doing some work at the moment about the way that we handle internal and things that come to us from the external environment, and part of that is to disaggregate what is actually being told to us and to understand how to engage with it better. So we are in the process of disaggregating. We are thinking about people who raise concerns, people who actually have complaints, and those who might formalise through whistleblowing, and all of that is gathered, and we plan to share it in terms of how we then inspect and regulate. And at the back of that disaggregation, one of the things that we are doing at the moment, which is throwing up some interesting insights for us, is around working with our colleagues in the National Contact Centre to actually train them to have better conversations when people contact us, so that we are actually becoming better at listening and better at hearing and better at capturing what people are telling us. And what we have to do then is to, working with Emma, is to make sure that in the capturing, listening and hearing, that we are sharing that appropriately across the organisation as well. So the information and knowledge strategy and the tree that is set out is actually very key and helpful in doing that.
Thank you. Emma, I just had one point myself, or 2 points actually. On page 9, there's a list of investments that the CQC needs to make. I don't think we should discuss them now, but it does, apart from Oracle, which Eileen's going to touch on in a moment, there's about £10 million of investment. And I think if Camilla was here, I think she would undoubtedly ask, when are we going to see the case for making the £10 million investment? So maybe at our next board meeting, as part of the, not as part of the adult social care report, but as part of that sort of piece of the agenda, you might come back on the £10 million of investment. The other point I had was, and it's really, I just don't know this, do we have the names of everyone, for example, who is in a care home, or the name of their relatives? Do we have that information? Do we have the power to ask? The reason for this question is, if we knew the name of everyone, or their relative, and an email address or a mobile phone number, that just gives us the ability to, for example, for the call centre to do outbound calling, to find out, how their relatives are being treated, whether they've got concerns. I was also very taken by Mike's point that the response rate, the bereavement response rate, was 40%, which is, incredible. That, if we had better knowledge, or if we were if it was in our power to actually request the names, I think that would be extremely helpful for our intelligence gathering. I don't know, Andrea, whether we've got that power.
So just to update you, Chair, one of the things that we're doing with the domiciliary care agency inspections is asking the service provider to give us the names and addresses of the people that they are providing a service to. And so we have been sending those people questionnaires to ask them what their views of the service are, and also to ask them if they can put us in touch with their relatives too. So we have been doing that as part of the inspections that we're undertaking at the moment. It's going to be one of the things that we will evaluate in terms of finding out how useful that is and how much we get back. What we also do is use our experts by experience to telephone some of the people using those services, so it's more of a qualitative conversation as opposed to completing a survey. It is, despite the fact that we're trying to do those things, so we do have the ability to do that, I think that we always have to be mindful, particularly in domiciliary care services, that folk are very often very reluctant to share their opinions of the service, particularly if they have concerns, because of the concern that they might have about what would happen subsequently. You know, however much we're obviously absolutely clear about confidentiality and all of those good things, we are, you know, I mean, I think that Anna's, the Health Watch's report, which was grateful today, powerful tomorrow, we still have a very grateful today population, and also a very nervous population, particularly when the only people that they might be seeing is the carer that's coming in, and undermining that relationship is a worry. So there were practical things for us to get over in getting that. From a residential point of view, it's easier because obviously when we go in for inspections we can speak to people. Very often we can speak to relatives who are there. One of the things that we're also exploring though is, and again this is tricky for us because we do unannounced inspections, and there's good reasons for that, but how can we actually access information from those relatives who we don't see, and particularly where we're inspecting services where people may not be able to express their views to us on a personal basis. So it's something that we have absolutely at the forefront of our minds.
That's extremely helpful. I think if we could, first of all, thank Emma for this update, and I think the next board meeting, when you come back on adult social care, perhaps we can take into account the comments of board members, including Andrew's important point that, you know, there are some parts of adult social care where it's very difficult to obtain information because of this frighten today, you know, power tomorrow problem. And when I was at the call centre, I actually heard a call like that. It was only because the relative in the end was so desperate that they called the call centre, and the reason that they hadn't called for 12 months of very poor care was exactly this, being frightened of the consequences. So it would be very good if you could deal with this issue, including, I think, Paul's very important point that so much of the information here is necessarily qualitative. It's not just that it's not quantitative. I mean, it is just the nature of the issues certainly in adult social care seem to me to be qualitative issues. You know, they're not prone to, you know, but data itself doesn't really help. So thank you very much. If we could now go on to the Oracle funding request, which Eileen's going to take us through. I think it's worth mentioning, this is item 10, that this isn't about whether to continue with Oracle. That's the subject of a larger piece of work that's going on. Eileen's going to just take us through the options for how we, the financial options for how we're going to continue with Oracle over the sort of next 12 months or so.
Thank you, Michael. I mean, just as Andrea said, you should never work with, you know, children, animals, or IT. I sort of feel like I have the thrilling job of trying to make a paper on Oracle licenses engaging. But just to give you a sense of how reliant we are on this, it's always good to give a bit of colour. Oracle supports our CRM system, through which I'm told 14 billion items of data were processed in the last year. So we are heavy users, and we're talking about systems which are critical to us. And certainly in the medium term, we will be Oracle reliant. And this paper is about allowing us to remain within the parameters of using Oracle legally. So this is something we would have been bringing to the board in any case in May time, because our licenses expire in June. So this was not a discretionary spend, it is something we would have to do. Just less than a month ago, the Department of Health alerted us to the fact that they had been offered, they are in the same position as us in terms of renewing their licenses. They had been offered a discount rate if orders could be placed by the end of April for license renewal. And we are keen always to achieve value for money. We had worked through the best and most plausible procurement route for us already, and then this stepped in, allowing potential savings of in the region of £250,000, which is important to us to achieve. It has meant that the people working on this procurement have pulled out all the stops. We have achieved the I haven't been at CQC long, but I'm assured it's the fastest agreement to a business case that there has been around a major procurement thus far involving the Department of Health, so I commend them for that. And I, you know, can't make it more exciting than the fact that this is something we would be doing already, and in engaging with the various parts of the procurement on offer procurement cycle, this is has been tested, and we are provided with internal assurance to CQC and assurance from the Department of Health that is the best route to go. So I'm asking for you to endorse what's been set out here.
Any comments, or is the board happy with going for option 2 and the discount?
Yep.
I'm assuming that we're getting the discount, or the government is getting the discount, because April the 30th must either be Oracle's, you know, the end of Oracle's financial year, or something to do with that. They just want to get the revenues in. So thank you very much.
You're more cynical than I, of course, Michael, but I'm sure there's more than a grain of truth in that.
Right, now Anna has circulated an exhibit or a slide for her to talk to about this issue on Health Watch's perspective on the hospital inspection process. So, Anna, over to you. This is item 11.
Thanks very much. So I'm not going to talk through the detail, and I'm conscious that you've only just got it anyway. So that probably isn't the point. But I think I wanted to, I undertook to bring something to the board to give you a sense of what we were trying to achieve when Camilla asked the question at the last board meeting, well, what would Health Watch bring to the inspection process? So I thought it was a good opportunity, sort of now we've gone through the first waves of hospital inspections, and as we're starting inspections in the other sectors, to reflect on what we'd learnt and what our ambition was. I have to say, this is not just from the Health Watch perspective. Catherine Rake, our Chief Exec, who I would have asked to be here to present this, but normally, but she's on holiday this week, so it falls to me, has been working with Paul, and the team have been working with Mike in particular around the hospital inspections, trying to work this through. But I think it's quite helpful to take a kind of step back from this. And I'm going to reference David Behan in his role at the Department of Health, who always said to me when I first took on this job that it was his ambition. It wasn't an accident that Healthwatch was located in CQC. It was part of realising an ambition that there was a very positive and potentially synergistic relationship around the inspection process. And I think for lots of reasons, partly because the inspection process has been so up in the air and in development, and most particularly because Local Health Watch didn't really exist until this time last year and have been in setup mode. We haven't realised that ambition in any way, shape or form really. So so this is about trying to realise that ambition, trying to find the place where the work of Local Health Watch and Health Watch England and CQC can really deliver some added value. And I hope we would want to do it whether we were part of CQC or not, but the fact that we are and that I'm here means that it gives us a kind of good impetus for doing that. And I think if Mike might want to comment in a minute, but if Mike was asked to comment on the way that Local Health Watch had been involved in the Wave 1 and Wave 2 inspections so far, he'd say it's patchy. And I think I've gone on record at the meeting saying, well, it's patchy in two respects, because one is, one respect is that Local Health Watch haven't always been able and haven't had the capacity or the capability to be involved, and the other is that CQC hasn't always remembered to engage with them or do it in a way which is fit for their purpose. So there's learning on both sides, which is reflected in here. And just thinking particularly about the Local Health Watch dimension of this, I think one of the really important differences in the Health Watch formulation from the previous Genesis in Link is the very existence of Health Watch England. So it's very clear to us that we have an important, and I'm glad to say very much welcomed role, welcomed by Local Health Watch that is, to help them to do things in a which will inform the improvement of service for user benefit. And so they're very, very keen to have us support them in engaging with the inspection regimes. Some of them are already doing it. They see it as being hugely important. Most of them want to do it, but they don't always know how to do it. And so there's a very important link, not just between CQC and in particular local CQC inspectors and local health watches, but between CQC and Health Watch England, so that we can play our part in helping Local Health Watch to fulfil their part. And this kind of sense of what the purpose of the whole thing is, and how we oil the wheels, and how we, between us, Health Watch England and CQC, make it work, is part of what we will then roll out with Local Health Watch. So we have an item in our budget and business plan for next year, which is around supporting Local Health Watch engaging with the inspection process, and there'll be a whole host of work around that, including training and data for them and all sorts of things, which will hopefully arrive at a point where there's a much more consistent engagement from Local Health Watch when inspectors want to talk to them. So that's a kind of general proposition. I think the only other general thing I want to say, and it speaks to these three phases. So phase one is, actually not to do with inspection, it's to do with registration, and some of the discussions we've had here about making sure that registration is also based on good intelligence and etc., and ongoing surveillance to support the risk analysis and intelligence package that we've just been talking about. The second phase is about actually during the inspection and the way that Local Health Watch and CQC might work together, and the things that Local Health Watch might contribute to that. And perhaps the surprise in the box is the third phase, which is post-inspection. And two things to say about this, and then I'll be very happy to take questions. So I think the first thing is, this is not in any way suggesting that Local Health Watch become part of the inspection function. but it is to recognise that Local Health Watch hopefully will have things which they can usefully contribute. That's point one. But second, it is that Local Health Watch is located in the communities which are experiencing good, poor or indifferent service from a range of different service providers, and who are left there after, as it were, the inspectors have left town, and who potentially have a really important role to keep from the Local Health Watch perspective, perhaps particularly to keep a weather eye on how things are developing and whether they are improving, using, for instance, their interim view powers to test things out and feed that back to CQC and to service providers. So a variety of things which they can do in that respect. But that being in the community is one of the things that I think is really important to sort of wrap around the notion of Local Health Watch. It's, you know, they're there, they should be engaged with local voluntary and other third sector organisations. They will be at the Health and Wellbeing Board, CCG very often. They'll be engaging with the providers. So they have a series of their own local intelligences and relationships which should help them to help all of us improve services. And that's why phase 3 is there, but that's why phase 2 also talks at the very top about providing a community narrative ahead of inspection. So it's kind of that sense of community. So more work to be done on this. Paul Bate and on behalf of all the inspectors, I think, is now working with Catherine and my team to kind of develop this and think about how we might make it fly across the inspection regimes. But I just thought it might be helpful to share it with you, and I'd be very happy to take any questions or comments.
Any questions, Paul?
Comment really. We often talk around this table about the importance of improvement, but we're not allowed to be involved. And by the look of it, you are. Now that's really significant, I think. Because we have a foothold in the next step. And it's been a constant worry to me that we had no relationship with the next step, almost by statute, no relationship with the next step. But actually, you know, the local health watches, if we can build this up so that, in a sense, they are representing the community and looking at the improvement activity as it happens or doesn't happen, then all the inspectors through CQC and Health Watch have a view of improvement without being involved in it. And that is potentially, I mean, starts to deal with the worry that I think we've all had about the problem that we'll be judged on the impact of something that we're not involved in. Whereas actually there is, as I say, there's a foot or a toehold in that improvement. So how the training for that develops, I think, is potentially really important. You know, how can we assist Health Watch localities to actually, what should they be looking for? How should they be judging improvement? How, you know, and we know a lot about this, but so how do we get the information across?
Thank you, and thank you, Anna. The diagram is actually really helpful, but looking at it through the lens of adult social care, you know, quite a lot of kind of what's referred to here sort of links very much to the set piece events, which are, you know, a significant hospital or, you know, mental health service or community health service being inspected, or the kind of phased approach that Steve will have around primary medical services. Whereas I think that for us in adult social care, actually what's going to be absolutely key is having an ongoing relationship between the local health watch and the local inspection teams, so that there is an appropriate exchange of information and understanding of what both are doing, because, you know, we're as I've mentioned earlier already in the meeting, our inspections are unannounced, so that whole kind of getting information ahead of it is a little trickier. So in a sense, what I kind of like to see is something that underpins the three blobs that we've got. I'm sure there's a more technical term than blob, but you know what I mean. The three blobs, which is actually about the ongoing relationship and strengthening that across with our local teams, and that will apply, I'm sure, for Mike and Steve as well. But that would be the real focus for me in terms of how we would work together. And it's also, I think, something that we need to think about in terms of how we can feed back information to Local Health Watch of what's happening in the local health and social care economy. So given that it's based on a local authority area, some of the conversations that we've had separately about whether we should be, when we get to this, the ability to do this, presenting reports by local authority area which would map onto Health Watch, which is saying, well, this is what we're finding in the hospitals sector, this is what we're finding in primary medical services, this is what we're finding in adult social care, and that actually being a very useful reporting mechanism for Local Health Watch to use to guide their ongoing activity as well. So.
Yeah, thank you. I mean, as usual, I would agree with Andrea. So we're building our, which is very similar in primary medical service to adult social care. So we're building our model, as we said earlier, about integration from the bottom up. Our inspection managers will be linked to CCGs, which by definition then aggregate up into local authority areas, although some cross boundaries. We will be in those areas all of the time, so it isn't an episodic inspection. We're going to link in the Mike's hospital and mental health inspections into what we're doing, so that we will look at, as we said earlier on, mental health issues across primary secondary care, and also increasingly with social care, and that means our inspection managers will need to develop a relationship with those leading the Local Health Watch, and it needs to be in real time, the information. And I'm just wondering then, and I think Paul is the right person to be linking when we're talking about the intelligence, both soft and hard, that we're getting back, how we can build up that relationship so that you know in advance what we're doing. Albeit that we will also be doing, like Andrea, some unscheduled visits, particularly to areas where practices we're worried about. And we need a meeting to talk through that. And I think I'd like to have a meeting at least where social care is involved, because we also need to bond our inspection managers with Andrea's locally, so that they can cross-represent us at times rather than just one of the sectors. Because I think this concept of the one CQC and doing things once when you can is really, really important, even at a local level, not just with us being together.
Mike.
Just to say, it's very important for us to be working with both national and local health watch, and I think and hope it's now getting onto an even keel, in that we will always alert the Local Health Watch to the fact that we will be doing a particular inspection in the next quarter, so that we can get information from them before we go on site, and absolutely the point that Anna has already made about these three blobs, and the fact that at the third phase, Local Health Watch are always invited to the Quality Summit, and we've already had a webinar where we've tried to engage with local health watches in areas where we've already inspected, just to get their experience of that. And there are lessons to be learned, but I think we're on our way.
Lewis.
Can I ask about something that I suppose I've become aware recently of, the one curious feature of the whistleblowing status, which is the amount of vitriol that whistleblowers can sometimes be subject to in their own community. I suppose I've become more aware of this because of having met James Titcombe and through his involvement with CQC, which I find rather extraordinary, actually. Maybe it's well known, but I hadn't been aware of how unpopular people can be for raising serious and valid, ultimately vindicated concerns about their local service. And there may be some complex reasons for that. Perhaps people are afraid of the closure of services that they rely on and so on. But I raise it because presumably that is something that Healthwatch locally will have to deal with if it hasn't already. Perhaps not in very high-profile cases, but widely divergent and strongly held views, perhaps felt sometimes embittered views from people who are seeing attacks on the local service as being quite damaging. And I mentioned that partly as a general question to you about how that will be dealt with, but also I suppose you do in the middle section of your diagram refer to sense checking of inspection findings with Healthwatch, and I suppose there is that to me is the most intriguing part of the role, the question of checking out with people locally whether what the inspection is finding they recognise it, because that divergence of view locally could mean that is a potentially difficult and fraught process.
Emma.
So a few things I'll just deal with there. I mean, I think one of the reasons for wanting to bring this here is to try to join up the thinking across all three inspectorates. So I just welcome what you both have to say about making sure that this is fit for purpose across the piece. And it does absolutely take for granted that ongoing need for very close, and I think there are very close relationships between some local health watches and local CQC inspectors, but I don't think it's universal. And I think they felt the sense of flux in who's doing what and who's responsible for what, and are a bit confused by that. So perhaps now is a great moment, as everyone's been cut across into their directorates, to kind of rethink that and make sure that everyone knows everyone, and that foundation is strong. And nothing about thinking about the role of Healthwatch England in helping local Healthwatch should in any way detract from the idea that there needs to be very strong and present relationships between each local Healthwatch and the local inspectors. Nor should this be something which is just episodic. It must be ongoing. So we need to get the right format for this, which ensures that that's right. So yeah, please, more conversations over the next period before we finalise it. And I think that notion of kind of local authority by local authority reports would just be unbelievably helpful to local Healthwatch, actually, because it could kind of pull together everything that they need to know, which would help them direct their energies in the most appropriate way. So the whistleblowing. Someone actually on Twitter said, well, what are Healthwatch doing about whistleblowing? How many people have asked Healthwatch to help them, whistleblowers, to help whistleblowers and protect and defend them? And so I put out a question to my team, since that had come directly to me, to find out what we knew about how many whistleblowers had come to local Healthwatch. And actually, the answer came back none at the moment. Now, in some respects, I don't think that's a bad thing, because whistleblowers should go wherever they need to, wherever they can, and if they find their way to local Healthwatch, that's right. But and Healthwatch will we've done quite a lot of work with them on what they should do in those circumstances. But actually, whistleblowers are much better coming to CQC and others in the system who are better able to act more quickly. And the first thing we'd do if we got whistleblowing would be, if we were aware of a whistleblower, would be to pass it straight to CQC, because that's the place that something can be done about it. That notwithstanding, you're absolutely right that local Healthwatch and indeed Healthwatch England are subject to extreme and intense communication from some people who feel very strongly about aspects of service in their locality and don't feel that they're getting due attention. I think we are kind of as we speak, working through how we handle that and how we make sure that we are playing our part, but very often those individuals are also simultaneously having conversations with Contact Centre and CQC and with a variety of other organisations across the piece. So this is not on the whistleblowing question, but more about just the strength of feeling in local communities about services not being fit for purpose. And my biggest concern in this area, which I was talking to my team about, reporting back to me on next week, is to make sure that we know that this has landed in the right place, that everyone in the system is aware and responding collectively, and that no one is, we're not dropping the ball and no one is being passed from pillar to post with everyone failing to respond. So I think there is an issue there. It's the kind of no wrong door thing. Wherever it comes in, we should make sure that it's properly dealt with. Whether there is separately a role for Local Health Watch to support those who have whistleblown and are then condemned within their own communities, I think is another question which we haven't yet had to face. But I hear what you say, and we'll take it away to think about.
Anna, thank you very much. I think Anna is going to slip away now. There's only two other items on the agenda. One is the ACG report, but essentially John took us through it at the last board meeting, so I don't think, unless any board members want to, that we need to go through that, go through it again. I think the points are made very clearly. The board forward plan is actually not quite a forward plan, it's the agenda for the next board meeting, basically, which, again, unless colleagues think there's anything wrong with that agenda, we could just sort of say that that's fine. I don't know if there's any other business, any other issues that are on the board's mind.
Can I?
Sorry.
Apologies, I should have done this earlier, but Lewis has just reminded me that we'd just like to confirm that Malta Gerhold and one of our colleagues from our HR department interviewed for our National Patients Safety Advisor earlier this week, and I'm pleased to be able to confirm that we've done the references, etc., and that James Titcombe has been permanently appointed to that post. So we can announce that today.
That's very good. So this brings most of the board meeting to a close. It just remains to ask our attendees, public attendees, whether there's any issues on their mind that we can we should deal with. Yes, please.
Yeah, I was very pleased to hear Andrea stressing that people in social care were very reluctant to report concerns about it. And I imagine that that consideration was very much in her mind last October when she scouted the idea of using audio and video monitoring as part of the inspection process. And so I would really like to ask her if there is if she can give an update on her thinking, and in particular about sort of 4 points. One, will the final version of the provider handbook say anything about use of audio and video monitoring, because that will be very important as an encouragement to providers. Secondly, will she agree that it should never be forced on anybody? It must always be with permission of the user or the user's carer. Thirdly, does she agree that the main thrust in audio and video monitoring should be for overt cameras, both because they will prevent bad behavior and also because they will highlight good behavior, which is very important as well. And finally, whether cameras are particularly suitable in the area of home care, because that's an area where whistleblowing is not is simply, well, virtually impossible. And then I want to say something completely separately. Are the CQC inspectorates, the inspectorate using the raw data which health watches collect, because we have this signposting function, and a lot of issues of soft quality issues come to these, and sometimes we take these up with the providers or commissioners in question, and we get responses from them. And it seems to me that that would be extremely good, useful in the pre-inspection stage to all three inspectorates. Actually, what Lewis was saying earlier about there not being a great deal in the area of social care is reflected in the one in my own borough. Almost everything we get is about hospitals, a certain amount about GPs, but really much too little about social care. So those are my 2 points.
Andrea, could you?
Thank you very much. To respond to David's first point, thank you. At the same time as publishing the 3 provider handbooks for adult social care, we also produced an overview to those provider handbooks, which is this beautiful document here. On page 10, we set out the issues associated with the use of cameras and mystery shoppers, actually more on the covert surveillance side rather than the overt, but I mean, you make a very good point about that as well. What we've done in that is set out a fairly neutral position in terms of the considerations that we've got, 3 very specific consultation questions that we want to ask and get feedback from people, and we will be holding a round table later in May to have that further conversation, and so we'll be using the outputs of all of that to feed into the final provider handbook. So I'm very happy to give you my copy of this, David, so you can take it away.
Yeah, and I think on David's second point, it really does come back to the issues we've been discussing earlier about how to obtain information on sectors where there is no readily available information. Hopefully the next board meeting will be able to address David's point directly when, well, certainly as far as social care is concerned. Yes.
Thank you, Chair. 2 questions, if I may. One concerns the CQC website, whether it might be possible to develop this so that members of the public who have an interest in particular services such as hospitals could receive an email alert if there are inspection activities ongoing or in the immediate future, because it can be fairly difficult if you aren't frequently visiting a particular hospital, say, and for an example, in West Hertfordshire, the majority of patients would probably attend Stoke Mandeville Hospital in Buckinghamshire, recently inspected. And it may not be easy to find the information that there is a listening event, although this is geographically really quite close. The hospital quite close. And what is so striking to me is how the NHS is so much in compartments, so that the hospital is in not just a different county, it is in a different CCG, it is in a different area of NHS England from Hertfordshire, and it's in a different region of NHS England.
It's a very good question. I think the development of the CQC's website is a very important topic. Eileen, I don't know if the CQC actually is, now has a digital strategy, but I think the idea of alerts is actually an extremely good one.
We are developing a digital strategy, a coherent one. It's true to say we've probably had a number of digital strategies which have led to some improvements in places, but not in a terribly coordinated way. So we are actually beginning to draw all that activity together so that we are thinking about what the purpose of, for example, the website is, the external engagement that it allows for, how proactive and pushing it can be out to people who want to receive information from us proactively, and just how easy it is to navigate as well, because when you have an awful lot that you want to share with people, you can actually fall into the trap of making it so complicated that that mitigates against it. So we are really at the beginnings of that work and really drawing our thinking together and inviting thinking from people who have a view on what it's like to try to navigate some of our information, largely on the website, but in other ways as well. So that's ongoing, and it is going to not be an instant fix, is what I would say, but it's going to be done thoughtfully with a view to what works and what is proportionately affordable also.
Thank you very much.
And very briefly, if I may, a question about dentistry. The out-of-hours services are being inspected for primary medical services. Is there any intention to inspect whatever out-of-hours service there might be in dentistry? Because I am mindful that were I to get acute toothache tomorrow evening, my dental surgery will be closed for 4 consecutive days, and it would be quite a long time to wait until Tuesday morning.
Thank you. We're just starting to have a good look at dentistry and look back and look forward. As I said, perhaps before you came in, our deputy responsible for dentistry starts work on the 28th. We're shortlisting for the dental advisor this tomorrow, Thursday, and clearly we'll be listening, as Anna described earlier on, to people's concerns, and that could well be one of the areas we'll start to look at, because it's about joined up care, and in the GP out of hours and in hours work, that will all become part of what we look at in a CCG area. And in July we're also working with the president of the College of Emergency Medicine to look at how we can get feedback across from A&E about how some of those services work. So that's a really good question, and it's for the future, and we'll look at that.
Well, on that note, I hope that you don't get a severe toothache over Easter. But finally, I did want this meeting to end at 12:20 exactly. I haven't quite achieved that. But I think we've had a very productive meeting. And just 2 final points. First of all, to wish all the board colleagues a good Easter break. Unfortunately, it doesn't seem as if the weather's going to hold, but Paul is escaping it, so that's probably the answer. I also thought that from listening to the discussion, drew out 4 themes, which I think are potentially important for the executives to take on board, although I'm sure they're themes that they worry about the whole time. One is the CQC's role in improvement, which, as we know, is highly ambiguous. But on the other hand, I think at our last board meeting, or the one before, Paul Bate produced part of one of his papers was about the cost-benefit analysis that underpins the CQC, and almost by definition, the benefit is some sort of improvement. So I think, despite the way that the CQC's role is circumscribed, I think it is a very important topic. It may be that it's done through best practice dissemination. That's one way, I think, perhaps of having a role in improvement. But I think it is a very important issue, which I think future board meetings need to come back to. There's then the issue of intelligence, which I think we've had a good discussion about, but it remains highly very important, especially this whole area, as I mentioned earlier, that Paul raised about the importance of qualitative intelligence, particularly in adult social care. The third point, partly reflecting Mike's trip to Seattle, but also Lewis's point about Europe is, you know, what benchmarks should the CQC be using? And it just may be that there are international benchmarks out there which are helpful to, well, certainly the hospital inspection process, but perhaps to primary care and adult social care as well. And the final point was this notion, which I think the board has toyed with before, but I think is very important, that there's sometime soon there should be one geographic area in which there are simultaneous hospital inspections, primary care inspections, and adult social care inspections, and indeed which cover IAPT, so that the CQC can come to a view on or gauge the extent to which there is integration, or, as we know, that probably the result is going to be there's not very effective integration, what role the CQC can have in making integration more effective. So those are the themes that I took from this meeting, and which I, hope are reflected in future board meetings. So thank you very much for today. And I say we've almost made the 12:20, which I think is very good. Helped by the fact that we did have some apologies, but thank you.